with the Vietnam National Heart Association in providing educational content for this Congress. It has been, I'm sure, for all of you, a wonderful Congress, and it is our pleasure to now participate in this training village. This is an important session because it allows us to talk about very practical ways to become better at performing and interpreting echocardiography. In the time of COVID, when we cannot travel as much and when our ability to come to Vietnam and to go to different places all over the world, in fact, and engage in training is definitely not what it used to be. Doing this in a virtual format is a way that we can sort of try at least to overcome some of the barriers. The American Society of Echo is very pleased to participate in this session, in part because we are hoping to adopt a similar thing in other educational endeavors in different parts of the world, including the United States, given the fact that we are still under many restrictions in COVID. So in many ways, this is a groundbreaking session and something that's very important for us to explore as a way of providing education on practical scanning tips and tricks. So that said, I also have to say that even though we hope this goes well, we are very sad that we cannot be in Vietnam. As many of my colleagues in the United States who have traveled to Vietnam will say again and again, we wish we could be with you. You have such a warm country and you have such a wonderful people and such a wonderful medical establishment. And it is truly a joy to participate in congresses with you. And so, unfortunately, though we can't be there in person, we are happy to be able to spend some time with you virtually, but it will be much, much better for us when we can actually join in person in the future. And the same goes for anyone from Vietnam attending congresses in the United States. We'd welcome you with open arms to be able to participate together. So I believe that before we begin, there is an introduction video that the Vietnam National Heart Association Congress will supply, and let's go ahead and watch that now.
Tim mạch học là một chuyên ngành y học hết sức sôi động và thường xuyên được cập nhật. Đại dịch Covid đã và đang thay đổi sâu sắc thế giới. Mọi khía cạnh của đời sống xã hội bị ảnh hưởng nghiêm trọng và đặt ra những vấn đề thách thức chưa từng có đối với các thầy thuốc nói chung và các bác sĩ chuyên khoa tim mạch nói riêng.
Vinh dự và tự hào khoác trên mình chiếc áo blue trắng, mỗi người thầy thuốc chúng ta luôn tự nhủ, ngoài sự cảm thông, yêu thương người bệnh, chúng ta luôn cần phải trau dồi và cập nhật các kiến thức chuyên môn của mình. Học tập là một quá trình liên tục và xuyên suốt trong cả sự nghiệp hành nghề của chúng ta. Học từ các thầy cô, từ anh chị em đồng nghiệp và từ chính người bệnh của chúng ta. Vì thế, các hội nghị, hội thảo khoa học, các khóa đào tạo liên tục luôn là những cơ hội để học tập và trao đổi kỹ năng nghề nghiệp của các thầy thuốc tim mạch chúng ta.
Ngành tim mạch Việt Nam trong những năm vừa qua đã có những bước phát triển vượt bậc. Các trung tâm tim mạch trên khắp cả nước đã có sự phát triển về cả chiều sâu và về rộng. Hội Tim mạch Việt Nam cùng các phân hội là những tổ chức nghề nghiệp đã quy tụ được đông đảo các bác sĩ chuyên ngành tim mạch cũng như cộng đồng y khoa thông qua việc tổ chức các hội nghị, hội thảo và các khóa đào tạo liên tục. Hội nghị khoa học tim mạch toàn quốc năm nay là một minh chứng với sự tham gia của trên 300 các báo cáo viên, diễn giả nổi tiếng trên thế giới và trong nước, được phát cùng lúc trên 10 kênh trực tuyến và hàng loạt các chương trình đào tạo liên tục.
Chúng ta đã trải qua nhiều mất mát và thử thách, nhưng hơn bao giờ hết, các bác sĩ chuyên khoa tim mạch sẽ nỗ lực đoàn kết hơn. Sự nghiệp bảo vệ tim mạch sẽ không bao giờ nghỉ ngơi, không giới hạn và không khoảng cách giữa mỗi chúng ta. Chào mừng quý vị đến với Hội nghị Tim mạch Toàn quốc Việt Nam 2021.
Thank you very much for setting that up. Let's go ahead and go into our first talk. If we could have the slides up on the screen. We are very, very pleased to be able to welcome Dr. Thuy Nguyen. Dr. Thuy Nguyen is a specialist in cardiovascular disease. She has a long pedigree of having trained at very impressive places. And we are very, very grateful for her being able to join us today. Obviously, she has become an expert in echocardiography, and she is doing a wonderful job as a relatively new echocardiographer at Houston Methodist Hospital. You can see that she has been appointed assistant professor of medicine. I would also call attention to some of her latest publications here, in particular the one that you can see below on the screen right now. She is a true friend of the American Society of Echocardiography, and we are very pleased that she has agreed to talk to us today about this very important question. Can echocardiography be used instead of invasive right heart catheterization? A provocative topic, and I don't think there's anyone better who can address that for us today.
Hello, thank you so much for inviting me to be a part of the Vietnam National Heart Association scientific meeting. My name's Thuy Nguyen, and I will be speaking on right heart hemodynamics. Specifically, can echocardiography be used instead of invasive right heart catheterization? I have no relevant disclosures. This is an outline of the topics we will be discussing. Essentially, we will work on getting echo correlates of hemodynamic values obtained from right heart catheterization. We will start with a brief review of right heart catheterization. Right heart catheterization is an invasive hemodynamic procedure that allows direct measurement of right-sided cardiac pressures and calculation of cardiac output. It is commonly used to further assess patients with heart failure and/or pulmonary hypertension. Echocardiography is the primary clinical method for the non-invasive measurement of right heart hemodynamics. It's an indispensable tool for the initial assessment, diagnosis, longitudinal follow-up, and prognostication of patients with abnormal right heart function. Transthoracic echocardiography should be performed when pulmonary hypertension is suspected, as it may infer the diagnosis when multiple echo measurements are consistent. However, echo measurements alone are not sufficiently accurate to support treatment decisions. Right heart catheterization should be performed to further guide treatment. We will now discuss how echo can be used to estimate central venous pressure or right atrial pressure. Estimation of central venous pressure and overall volume status can be facilitated by echo via measurement of the inferior vena cava diameter and its change with respiration. As the right atrial pressure increases, this is transmitted to the IVC, resulting in IVC dilatation and reduced collapse with inspiration. The subcostal view permits imaging of the IVC. Measurement of the IVC diameter should be made at end expiration and just proximal to the junction of the hepatic veins that lie approximately 0.5 to 3 centimeters proximal to the osseum of the right atrium. Collapsibility is then assessed with sniff testing and determining whether it's greater than or less than 50%. For simplicity and uniformity of reporting, specific values of right atrial pressure rather than ranges should be used in the determination of right atrial pressure. An inferior vena cava diameter that's less than or equal to 2.1 centimeters that collapses greater than 50% with a sniff suggest normal right atrial pressures of 3 millimeters of mercury, whereas an IVC diameter that's greater than 2.1 centimeters that collapses less than 50% with a SNF suggests high right atrial pressures of 15 millimeters of mercury. In scenarios in which the IVC diameter and collapse do not fit either one of these paradigms, it's an intermediate value of 8 millimeters of mercury can be assigned. Here are some examples of how to assess for right atrial pressure. On the right is a normal right atrial pressure given the diameter of the IVC is less than 2.1 centimeters. In this instance, the IVC diameter is 1.2 centimeters, as seen in figure C. And there's greater than 50% collapse with inspiration, as seen in figure D. This would equate to an approximate right atrial pressure of 3 millimeters of mercury. On the left, elevated central venous pressure is demonstrated with an IVC diameter of 2.6 centimeters and no collapse on inspiration, as seen on the end mode in figure B. This would equate to an approximate right atrial pressure of 15 millimeters of mercury. There are some special circumstances when it comes to assessing the right atrial pressure that I'd like to discuss. It should be noted that in normal young athletes, the IVC may be dilated in the presence of normal pressure. In patients being ventilated using positive pressure, the degree of IVC collapse cannot be used to reliably estimate right atrial pressure, as the IVC is commonly dilated and may not collapse in these patients. An IVC diameter that's less than or equal to 1.2 centimeters in these patients, however, appears accurate in identifying patients with right atrial pressures less than 10 millimeters of mercury. In this same patient group, if the IVC is small and collapses, this suggests hypovolemia. In patients who are unable to adequately perform a sniff, an IVC that collapses less than 20% with quiet inspiration suggests elevated right atrial pressures. Let's now move on to discuss pulmonary artery systolic pressure. In the absence of obstruction of the right ventricular outflow tract or the pulmonary valve, the pulmonary artery systolic pressure is equal to the right ventricular systolic pressure. Thus, pulmonary artery systolic pressure is derived from the sum of the right atrial pressure, which you get by evaluating the diameter and collapsibility of the inferior vena cava, and the tricuspid regurgitation velocity obtained by spectrodoppler and calculated with the use of the simplified Bernoulli equation. So in this instance, pulmonary artery systolic pressure is equal to 4 times the tricuspid regurgitation velocity squared plus the right atrial pressure. So in this example, the tricuspid regurgitation velocity is 2.8 meters per second. If you put it into the simplified Bernoulli equation, you will get a pulmonary artery systolic pressure of 31 millimeters of mercury plus your right atrial pressure, which can be either 3, 8, or 15. While this calculation can give you a general idea of the pulmonary artery systolic pressure, inaccuracies in estimation can occur when either the tricuspid regurgitation jet tracing is not complete or in the presence of wide open tricuspid regurgitation. Also, keep in mind that in the setting of very high right atrial pressure, in which echocardiography may not accurately estimate right atrial pressure, the pulmonary artery systolic pressure estimate will be affected. To optimize your tricuspid regurgitation jet in order to calculate pulmonary artery systolic pressure, start by first optimizing your 2-dimensional image, focused on the tricuspid valve. Then add color to guide the continuous wave depth. The continuous wave line should be drawn through the origin of the jet and align parallel to the direction and the tricuspid regurgitation flow, as shown in these images. The maximum tricuspid regurgitation jet is variable and may be obtained from different views. Use the view with the highest velocity for your calculation, and only good quality signals should be reported. For example, tricuspid regurgitation can be obtained from an apical 4-chamber view, as seen here, or an RV focused view, or an inflow view, or a parasternal short axis view. You want to be as parallel to the jet as possible. Weak flow signals may be enhanced using agitated saline or ultrasound enhancing agents. However, if the signal is still weak after using agitated saline or ultrasound enhancing agents, the measurement should not be reported. In this image, you see that the tricuspid regurgitation jet is faint and incomplete. However, after giving an ultrasound enhancing agent, the tricuspid regurgitation signal is stronger, and you can see a more complete tricuspid regurgitation jet. Keep in mind this scenario when using ultrasound enhancing agents or saline. On the left, there's a tricuspid regurgitation signal that is not contrast enhanced and correctly measured the peak velocity at 2.6 meters per second, corresponding to a pressure of 27 millimeters of mercury. After contrast enhancement, the clear envelope has been obstructed by noise, and the reader erroneously estimated a gradient several points higher. In this case, they obtained a tricuspid regurgitation velocity of 3.4 meters per second and a peak gradient of 45. As this example shows, it's critical that only well-defined borders be used for velocity measurement, as slight errors are magnified by the second-order relationship between velocity and derived pressure. As mentioned before, pulmonary artery systolic pressure is equal to right ventricular systolic pressure in the absence of right ventricular outflow tract obstruction or pulmonary stenosis. However, in the presence of right ventricular outflow tract obstruction or pulmonary stenosis, the right ventricular systolic pressure will be greater than the pulmonary artery systolic pressure, as flow always travels from a higher pressure to a lower pressure area. In this instance, the right ventricular systolic pressure will be equal to the sum of the pulmonary artery systolic pressure and the pressure gradient across the pulmonary valve. If you were to measure the right ventricular systolic pressure and the pulmonary artery systolic pressure on catheterization, you would see that the pressures do not peak at the same time, as shown in the top image. The Doppler instantaneous gradient that is obtained by echo does not equal the peak-to-peak gradient seen on cath. The peak-to-peak gradient is best estimated on echo by using the mean gradient across the pulmonary valve. However, in severe pulmonary stenosis, the pulmonary artery pressure flattens, and thus Doppler instantaneous gradient approximates the peak-to-peak gradient as shown on the bottom image. We will next move to the calculation of pulmonary artery diastolic pressure. Pulmonary artery diastolic pressure can be estimated from the velocity of the end diastolic pulmonary regurgitation jet using the simplified Bernoulli equation, where pulmonary artery diastolic pressure equals 4 times the end diastolic pulmonary regurgitation velocity squared plus the right atrial pressure. Measurement of end diastolic pulmonary regurgitation velocity is depicted by point 2 on the provided image at the red arrow. Point 1 corresponds with the early pulmonary regurgitation velocity, which can be used to estimate mean pulmonary artery pressures, as we will see on the following slides. We will now move on to discuss mean pulmonary artery pressure. Mean pulmonary artery pressure can be determined in 4 different ways on echo. I will go into each one individually. Once pulmonary artery systolic and diastolic pressures are known, mean pressure may be estimated by the standard formula: mean pulmonary artery pressure equals 1/3 the pulmonary artery systolic pressure plus 2/3 the pulmonary artery diastolic pressure. As previously discussed, the pulmonary artery systolic pressure and the pulmonary artery diastolic pressure can be obtained by using the simplified Bernoulli equation, where the peak tricuspid regurgitation velocity is used to calculate the pulmonary artery systolic pressure, and the end diastolic pulmonary regurgitation velocity is used to calculate the pulmonary artery diastolic pressure. As I mentioned earlier, mean pulmonary artery pressure can be estimated by the simplified Bernoulli equation using the early pulmonary regurgitation velocity, noted as number 1 on the diagram. Thus, mean pulmonary artery pressure is equal to 4 times the early pulmonary regurgitation velocity squared plus the right atrial pressure. A third way mean pulmonary artery pressure can be assessed is by using the mean tricuspid regurgitation velocity, which is obtained by tracing the tricuspid continuous wave Doppler signal and then adding right atrial pressure. In this instance, the mean tricuspid regurgitation velocity equates to a pressure of 39 millimeters of mercury. Add to this your right atrial pressure, and you get a mean pulmonary artery pressure. Finally, mean pulmonary artery pressure may be estimated by using the pulmonary acceleration time, measured by pulse Doppler of the pulmonary artery in systole, whereby mean pulmonary artery pressure equals 79 minus 0.45 times the acceleration time. Acceleration time is measured as the interval between the onset of ejection and the peak flow velocity. This is indicated between the 2 white dotted lines. Moving further along, we come to measurement of pulmonary capillary wedge pressure. Using the mitral inflow E velocity, obtained by pulse wave Doppler, and the early diastolic velocity of the mitral annulus, obtained by tissue Doppler imaging of the septal and lateral sides of the mitral annulus, you can obtain an estimate of pulmonary capillary wedge pressure. Pulmonary capillary wedge pressure is calculated by using the ratio of the E to E prime, where an E to E prime ratio that's less than 8 is usually associated with normal left ventricular filling pressures, while a ratio that's greater than 14 is associated with increased filling pressures. For values between 8 and 14, there is a gray zone with indeterminate filling pressures. It is preferable to use the average of the E prime velocities obtained from the septal and lateral sides of the mitral annulus for the prediction of left ventricular filling pressures. Because septal E prime is usually lower than lateral E prime velocity, the E to E prime ratio using the septal signals is usually higher than the ratio derived by lateral E prime. The graph above is from Dr. Naga's paper, which showed that using E to E prime allowed for good correlation with pulmonary capillary wedge pressure, and that above an E to E prime ratio of 14 revealed elevated pulmonary capillary wedge pressure. Here's an example of a patient with an elevated pulmonary capillary wedge pressure, where the E to E prime ratio is 20.5, so greater than 14. They also demonstrate an E to A ratio of greater than 2, with a short deceleration time, as depicted by the white line. Their pulmonary venous systolic flow is blunted, and all of this is consistent with an elevated pulmonary capillary wedge pressure. Pulmonary vascular resistance is another useful measurement that can be estimated non-invasively with echo. Pulmonary vascular resistance is calculated by dividing the pressure difference across the pulmonary circuit by the transpulmonary flow. Peak tricuspid regurgitation velocity is used as a surrogate for pressure, and the right ventricular outflow tract velocity time integral is used as a surrogate for flow. Abbas et al. Demonstrated that peripheral vascular resistance can be estimated from these values. At lower peripheral vascular levels, such as less than 6 Witts units, the equation tricuspid regurgitation velocity divided by right ventricular outflow tract velocity time integral times 10 plus 0.16 showed good correlation with catheter-based measurements. However, at higher peripheral vascular resistance levels, greater than 6 Witts units, a quadratic representation better correlates. So you should use tricuspid regurgitation velocity squared divided by right ventricular outflow tract velocity time integral times 5. We will now briefly discuss a couple of measurements of cardiac function, beginning with right ventricular stroke work index. Right ventricular stroke work index is a measure of work done by the right heart with each contraction. Indexing stroke work reduces the influence of loading conditions on measurements of systolic function. This is traditionally an invasive parameter that helps assess cardiac contractility. Higher right ventricular workload is associated with worse outcomes after lung transplant. On the contrary, lower right ventricular systolic work index is associated with worse outcomes after heart transplant. Right ventricular stroke work index can be measured using the equation mean pulmonary artery pressure minus the right atrial pressure times the stroke volume index, where stroke volume index is equal to the area of the left ventricular outflow tract multiplied by the velocity time integral of the left ventricular outflow tract divided by the patient's body surface area. Finally, we will touch base upon how echo can be used to estimate cardiac output. Cardiac output is a product of stroke volume multiplied by the heart rate. In the absence of significant aortic regurgitation, the velocity time integral of the Doppler signal obtained from the left ventricular outflow tract multiplied by the cross-sectional area of the left ventricular outflow tract allows a non-invasive estimation of the stroke volume. This has proven to be fairly accurate despite the generally oval shape of the left ventricular outflow tract, rather than the assumed circular shape in echo Doppler measurements. Obtaining the right-sided cardiac output is done in a similar fashion by using the right ventricular outflow tract velocity time integral and area. However, this may be more susceptible to inaccuracies because the right ventricular outflow tract geometry is even more variable than the left ventricular outflow tract. If you're going to be measuring the left ventricular outflow tract diameter, it should be done in the parasternal long axis view in mid-systole from the white and black interface of the septal endocardium to the anterior mitral leaflet, parallel to the aortic valve plane and within 0.5 to 1 centimeter of the valve orifice. We have now gone through how to obtain right heart hemodynamic values using echo. While this can be extremely useful information, the data obtained can only be as good as the images used to derive them. It is important to keep this in mind and to optimize echo imaging prior to using the equations we discussed. Otherwise, the information can be quite misleading and affect patient care. Thank you again for having me be a part of this conference. If there are any questions, I will be happy to answer them. And please feel free to contact me as well. Thank you.
Well, thank you so much, Dr. Nguyen. That was phenomenal. I just am very pleased that you're able to join us live as well as doing the video. Really appreciate that. I'm wondering, could you tell us a little bit more about this RV Stroke Work Index? It's something that I think a lot of people are less familiar with. We know that we can use echo to estimate it, but how would you use this in a clinical setting?
Yeah, to be honest with you, I think it's one of the parameters that we don't commonly obtain. I think, getting the right atrial pressure with IVC, getting the pulmonary artery systolic pressure, those calculations, and even the pulmonary artery diastolic pressure is way more common in our echo reports, even here in the United States. I think the right ventricular stroke work index is actually a really good marker of right ventricular function. As you know, the RV, the shape, the dynamics of it, it's much more intricate than I think some people give it credit for. I think a lot of us focus more on the LV. When we get an echo report, it's what's the LVEF? How does it look? Are there any wall motions? But the right side is quite important. If you can't get blood from the right to the left side, there's no point. The RV Stroke Work Index, you really get it by using the mean pulmonary artery pressure. And as I showed, there are 4 ways of doing that. From the literature, it seems that getting it from the tricuspid regurgitation velocity mean pressure is generally what I've seen in the literature used. It's then, subtract the right atrial pressure and then divide by the patient's body surface area. I'm interested in what you do in your lab, Dr. Kirkpatrick.
That's a good question. I have to admit, we have not adopted routine reporting of the RV Stroke Work Index, but we are currently actually in talks, I guess, if you will, with our colleagues from the pulmonary vascular group. We have some pulmonologists who are very savvy with using echocardiography, and we are having a big discussion right now about which echo parameters are going to be the most important in the echo reports and for routine measurements in order to help patients with not only patients with known high pulmonary vascular resistance, but also those who need to have a differentiation between high pulmonary vascular resistance and high filling pressures on the left side, and then integrating all of that with the right ventricular systolic function, which is such a key parameter in pulmonary hypertension. So we are not as probably far along as you are, and I would guess certainly as UCSF was in that. But I would actually like to, I didn't ask her if it would be okay, but I would like to ask Dr. Y, what is the use of echo hemodynamics and echo swan versus invasive swan in Vietnam or at Bach Mai Hospital?
In Bach Mai Hospital, we do echo to estimate hemodynamic parameters for many patients, for valvular disease patients, for patients with congenital heart disease. Especially, we have many adult congenital heart disease, and so we do a lot, and we use Doppler parameters like right ventricular systolic pressure and pulmonary artery pressure, mean and systolic and diastolic, and also QP, QS. But we haven't adopted RV stroke volume. This is very new today. This is very interesting for us to hear, to learn from Dr. Thuy Nguyen about a new parameters and how to do it in clinical practice. And may I have a question for Dr. Thuy Nguyen? We have many repaired defect, congenital heart disease like repaired tetralogy of Fallot. So can you comment on the estimation of pulmonary artery pressure in repaired tetralogy of Fallot patients? Do you use RVOT Doppler or TR flows? Does RV function affect the measurement, and how to make to clarify the result? Yes, sometimes we find it very, very hard, especially in patients with poor RV function or severe pulmonary regurgitation.
Yes, congenital patients are quite difficult, even just obtaining their images. You have to often use off-axis, planes. You have to, you get way more images in these patients just because their anatomy is so unique. To be completely honest with you, the echo guidance for congenital patients are good, but we will generally, if we want really good hemodynamics, we actually will take most of these patients to catheterization. So that's kind of, to get our true diagnostic information that we need, especially for interventions. And if the patient's not doing well, that's kind of where we would go. Dr. Kirkpatrick, do you have anything to add?
Well, to be honest, I was going to ask you that question too, is when do you think echo is going to be able to replace invasive catheterization? And go ahead.
Well, based on the guidelines, unfortunately, I don't think echo is ever going to be able to replace it currently. I think echo is a good guidance. So in patients who you have suspicion of pulmonary hypertension, it's a good idea, to start with an echo. And if the pulmonary artery systolic pressures are elevated, that might prompt you to move on to catheterization. In the European Society guidelines for pulmonary hypertension, it actually says, for treatment, echo should not just be used. You really should take the patient to catheterization. Although with catheterization, it's an invasive procedure. Complications can occur. It's very rare, but it does happen. And obviously it's not always available. But I think for a patient where you already have a diagnosis of pulmonary hypertension, it can actually be used for longitudinal guidance and even prognostication.
Yeah, I would agree completely with that answer. We're not in the place of replacing, it's an augmentation. And in some ways it allows, or it's done for different reasons, just as you said, which I think is great, and frequent follow-up and all the prognostic information and correlating it with the measurements of right ventricular function, which are hard to do by 2D, easier by 3D. And of course, strain is going to play a role as well. But there is at this point no substitute for the invasive determination, at least in the way we practice, I would say. But certainly it doesn't mean that echo isn't incredibly important. And we appreciate so much your excellent talk outlining that. And especially I really appreciated your discussion of how to augment the tricuspid regurgitant jet, something that I think we need to keep in mind all the time, especially when we need that number. And I would encourage all of us to use that more. Dr. Huai, any other thoughts or comments?
Thank you, Jim. Yeah, please go ahead.
Well, we're going to have more time to talk to Dr. Thuy Nguyen later on in the question and answer session. But for now, we would like to move on to our next speaker, and that is Mr. Todd Zwink. Todd Zwink is a sonographer. Now, sonographers in the United States are more than just technicians. They actually play an incredibly important role in the imaging of patients. Now, some people in Vietnam might say that we in the United States as echocardiographers are lazy because we don't do our own scans and we rely on sonographers to do that. And they may be right about it. My echo skills, I'm sure, are not as good as Dr. Huai's at all. However, this is a way for us to be very efficient. Someone scans, another person reads, and that's why we do that. But Mr. Zwink is a true expert. He has been at the University of Washington leading the Echo Lab for many, many years, many decades actually. And he is one of the best scanners I've ever seen. And more than that, he's one of the best people to educate others in how to do the scanning. And so we are very, very pleased to have Todd come and give us this talk on pericardial imaging.
Hi, my name is Todd Zwink. I'm the supervisor of the Echo Lab at the University of Washington Medical Center. I'm very excited to present on pericardial imaging. The session, I guess, is practical tips and tricks for advances in echo. And I'll be talking about, my topic is pericardial imaging. So I'll be talking primarily about pericardial effusions and how we image those here at the University of Washington Medical Center. And I really hope that you find this useful and practical, and we'll get started, all right? Oh, 1 second. Okay, so I don't have any disclosures. So imaging pericardial effusions. Echo is really considered the first-line imaging modality in imaging patients with a pericardial effusion for a lot of different reasons. One, it's readily available. It's also low cost, it's safe, it's portable. We have high frame rates compared to some other modalities. And we also have the use of a respirometer, which I'll be talking about in length today, because I really think respirometers really help us determine kind of the consequence of the effusion on the heart. So I really want to talk about the kind of technical aspects that we try to address when we image these patients. So for the 2D, we definitely like to have kind of a soft gain setting. We want to increase the dynamic range or the compress, depending on what system you're using, and maybe slightly overgain to kind of really help bring out some hypoechoic structures that may be in the fluid. One of the things that's really important is long clip lengths. A lot of what we're evaluating for is kind of septal motions or chamber sizes over the respiratory cycle. So just having 2 or 3 cardiac cycles oftentimes isn't going to be long enough to show some of those respiratory type changes that we're looking for. Also, be aware of cardiac motion in 2D planes. Now, always, since we're using tomographic planes, there's always concern that we're not cutting things completely perpendicular, that we're foreshortening. But this is even a little more concerning when the heart has this additional motion because it's in fluid. So just definitely check multiple planes. Oftentimes using a short axis plane if you've been looking at a long axis plane. Also, X-plane is a great option if you have that available on your system to be able to show the 2 planes at once. So I just want to show this clip here for a couple of reasons. One, you can see it's a very contrasty image. You get the feel that there's structures in the pericardial space, but the dynamic range is turned down, the compress is turned down. It's a very contrast image. The gains are a little bit low. And it's really hard to define any of that in this clip. The other reason I want to show this is it's only a 2D clip. It looks like right at the end of the clip here, probably during expiration, you're starting to see what could be some right atrial collapse here. But it's hard to determine if it's that or if it's just atrial systole because of the shortness of the clip. Obviously, if this were extended out, you'd be able to look for those kind of changes over time. So. And then this, again, just talking about cutting planes. This one, it's pretty obvious that we're just kind of sweeping outside of the right ventricle because you can see the epicardial surface here. But sometimes chambers look like they're getting smaller, and it might be more respiratory motion than or clip, or kind of a slice plane versus actual changes. So you just want to be conscious of that, and then check other views. This would be a great opportunity to do like a short axis through here and see how that looks throughout the respiratory cycle in a short axis clip. With spectral Doppler, really the big thing is using slow sweep speeds. You really want to increase the number of cardiac cycles you can see, and then kind of look for those respiratory cycles over time and see what changes there are. It's really helpful to decrease the gains, especially if you're slowing the sweep speed down, because you're going to compress the amount of information you have on that one image. If it's really noisy, it's kind of harder to see the waveforms that you're looking for. And there's still that same concern for cardiac motion. Just making sure, you want to make sure that your sample volume position is going to be consistent throughout the respiratory cycle. So you're always getting flows through the structure that you're looking at. So this is one view that I want to show where the gains are nicely set, so you can see the waveline profiles really well. It's also a nice slow down clip where we're seeing looks like over 10 cardiac cycles, but we're also seeing 3 full respiratory cycles through here. So this is really helpful in being able to determine kind of what kind of changes we're seeing over respiration. And this clip is just to show kind of some of those changes that we're seeing with cardiac motion in regards to the sample volume. You can see a lot of kind of cardiac swinging here in the pericardial space. A majority of that's the apical side, but the base seems to stay more in place here. But again, the sample volume doesn't really stay kind of where you'd expect it to. So you really want to set up your sample volumes, make sure you kind of watch it throughout the cardiac cycle, make sure it stays where you want it to be, and oftentimes take a nice long clip of where the sample volume is so that you can show that you're still scanning through the structure that you're hoping to throughout respiration. All right, M-mode. M-mode is a great tool for looking at changes in chamber sizes, looking at motion of the septum, those kinds of things throughout the cardiac cycle. But again, you just need to slow the sweep speed down so you can really kind of see that more over time. So this is a really nice clip. So costal 4-chamber view. You can see a pericardial space, both medial and lateral to the heart, right ventricle here. And although we don't have a respirometer set up on this image here, you get the impression that it is over through a couple cardiac or respiratory cycles. And you can see the changes in the right-sided heart chamber size here throughout the respiratory cycle. So this is, again, a great tool to really show that and really document how much changes there are over time. Okay, so respirometers themselves. Now, most new systems have this capability. It's set up to work through the EKG. And really, you just need to go to the utility settings on your system, or physio on some systems it's called. There's always going to be the EKG, but there's usually a couple channels that you can designate to the respirometer. So you click that on, that will enable it. But it does take a lot of adjustment to get it to work correctly. 2 things, the respiratory position and the respiratory gain are 2 things you really need to adjust. And unfortunately, it seems like you have to kind of readjust them throughout the study. And it seems like the adjustment for 2D is separate than the adjustment for Doppler and M-mode. So you can get it just right for your 2D, but then going to Doppler and then realize you need to readjust it again. So just be cognizant of that. It can be a bit problematic. It doesn't always track well, but it is a really good tool, and it really helps us kind of define what we're looking at. Just make sure you know how to get back into it to make those adjustments throughout your study. So here's a couple of examples where the respirator could have been adjusted a little better. This first image here, you can see that a nice long sweep of the mitral valve inflow, but most of the respirator information is cut off. So you can see they're breathing in here, but we can't tell when the beginning of inspiration occurred. You can see when they started to breathe out, but again, we don't know when they stopped breathing out and when they started inspiring again. So this, if they had changed the position of the respirometer and brought it up, then you'd be able to see the full waveform with the Doppler. And this one, similar issue, this one more with the gain. You can see it's getting topped off both here and it's getting popped off at the bottom as well. So in both positions, we're not able to see exactly what's occurring or when things are beginning. So if you had reduced the gain, that would make the waveform much smaller and you'd be able to see that on the screen throughout. The other option, if you don't have a respirometer, is to just annotate on the screen when the patient's breathing in and out. We do this a lot, and like I said, here you can tell they even attempted to put the respirometer on the patient or to turn on and activate it, but it's just not tracking. So it is kind of tricky to be getting Doppler information and kind of keep an eye on the patient and see when they breathe in, when they breathe out, see when that occurs on the screen, and then freeze it and then put those annotations correctly on the screen. It's a bit of a challenge, but it can be done. And so it really gives that additional information that our cardiologists will need to help determine how much, are these changes real with the respiratory cycle, or is it just because of cardiac motion or other issues? So echocardiographic determinants for pericardial effusion. The things that we want to determine and look at is whether the effusion is global versus localized, what's the relative quantity, what the appearance of the fluid is, and most of all, is there hemodynamic compromise? So we'll kind of go through each of those. But before we get into that, just to look at being able to determine pericardial versus pleural effusions, the adage is if the pleural effusion is going to extend below the thoracic aorta, whereas the pericardial effusion is going to be anterior to that. The other thing I like to use to just really document that as pleural versus pericardial is if you go to a short axis view and the fluid looks like it's sitting below the heart like a bucket of water, that's going to be a pleural effusion. Whereas the pericardial effusion is going to better mimic the shape of the heart, the cardiac silhouette. And this patient has both a pleural and a pericardial, so you can kind of see the contrast between those. Again, the pericardial effusion is going to be anterior to the descending thoracic aorta. So global versus localized, I mean, that's pretty obvious. The majority of pericardial effusions are global. The majority of our patients that have pericardial effusions because of cancer, those are typically going to be global, although a lot of our post-operative patients have global effusions as well, too. Here's some examples of some localized effusions. This patient is post-op and they have a posterior effusion. As far as localized effusions go, posterior is the most common. So you can see here both along the short axis views. This patient was post-aortic valve, tricuspid valve replacements. So the surgeons were doing a lot of work kind of in this area and along the right side of the heart. And you can see the effusion is pretty much in that same area, anterior to the heart here and medial to the right ventricle here. And this patient was post-heart transplant. They have a localized effusion superior to the right atrium. So you can see in this view, this is most likely where the anastomose is the right atrium. So this is all donor heart down here. This is native part of the native atria up here, and then a pericardial effusion up anteriorly. So for this reason, most of our post-op patients, we do like to kind of do extended depths when we look at our initial apical long axis views, subcostal views, to look for different areas of a localized effusion. We also want to kind of sweep through the heart, because oftentimes these effusions can originate in places that we don't normally look and expect to find them. Okay, moving on to quantity. So there is a study that where someone did a kind of method of disc, first traced the pericardial space and then traced the cardiac structure, and did method of disc volume analysis on both, subtract one from the other, and came out with a size of the pericardial effusion, which did correlate well with the amount of fluid that was drained during pericardiocentesis. So you can do that. It's a lot of work, and to be honest, it's really not going to be that helpful to find out the exact quantity of the effusion. Really, we just want to know if it's small, medium, or large, and we just want a quick and easy way to do that. So that's why this is kind of our continues to be a standard. And this is measuring end-diastole, just the pericardial space from the parietal side to the visceral side. If it's less than 10 millimeters, it's going to be mild. If it's moderate, it's going to be between 10 and 20 millimeters. And if it's over 20 millimeters, it's considered severe. Now, obviously, there's a lot of caveats to that, because you're taking one 2D measurement and to what's really a very complex three-dimensional shape, but it tends to work well enough for our purposes. Here's just some examples of different measurements. You just want to be perpendicular. There's no obvious rules. Some people do like to consistently measure posterior to the left ventricle, but oftentimes fluid collections are greater in different areas. The appearance of the effusion. So we want to know the selective weighted versus free fluid. Fibrin strands will suggest either inflammation or clotted blood within the effusion. The appearance of organized thrombus may change clinical management. If it's a post-op patient and there's a lot of thrombus within the pericardial space, they may opt to take the patient back to the operating room to remove that versus trying to drain it. And then fibrin strands may lack like the effusion. And that could be make draining the fluid more difficult as well too. This is a post-op patient with, you can see a lot of thrombus in the pericardial space along with the pericardial effusion. So this is primarily around the left heart here. You see a lot of thrombus, both lateral and posterior to the heart. And this one has a lot of fibrin strands. So you just want to be able to identify that. Our interventionalists will be interested in that too if they're looking to drain these. But again, you just want to set up your 2D to kind of be able to pick up those sometimes very hypoechoic structures in the patient. And this I just want to show because this is something that we commonly do, and this is just kind of sweeping through the effusion. It kind of shows part of the volume of the effusion. It may show an additional target that, posterior to the heart. There's a lot of volume there. But also we kind of can sweep through and see if there's any fibrin strands, any thrombus, anything that we won't be seeing at just kind of normal imaging planes. And then hemodynamic compromise. So this is really kind of the key to the evaluation. And really there's four main things that we're going to look for with that. Increase in central venous pressure. And obviously we're going to look at the IVC for that. Whether there's septal shifting with respiration, whether there's respiratory variation of right and left heart inflows and hepatic venous flow, and chamber collapse. And this is all due to kind of a term called interventricular interdependence, where when the pericardial effusion expands into that space, it expands at a point where it starts to pressurize the pericardial space. The pressure on the outside of the heart in the pericardial space is going to overpower the relaxing pressure of the heart and restrict the swelling. With inspiration, you have an increase in right ventricular pressure, which will decrease the amount of filling that the left heart can do. And consequently, on expiration, that's going to increase your left ventricular pressure, but it'll decrease the right ventricular filling. So this is a patient with a pericardial effusion looking at IVC collapsibility. Again, you can see the IVC is large. It doesn't collapse 50%. And these are the ASC, American Society of Echo guidelines for looking at central venous pressure, or estimating central venous pressure from imaging the IVC. So if obviously the IVC is normal in size and collapse, it's going to be around 3 millimeters of mercury. If it's either enlarged or not collapsing well, it's going to be around 8 millimeters of mercury. And if it's enlarged and not collapsing well, it's going to be around 15 millimeters of mercury. Simple shifting is a very dynamic, specific finding with pericardial effusion and hemodynamic compromise. Again, you're going to want to really kind of document, if you can, the respiratory cycle, which you can see here with the respirometer, as well as take a nice long lengthy clip to really kind of show the change over time. So in this view here, obviously you can see at the beginning of the clip with inspiration, the septum moving down towards the left heart, increasing the size of the right ventricle, but at the cost and filling up the left ventricle. This is a short axis view from parasternal, and this is using M-mode to look at that motion. Again, earlier I was talking about M as a great tool for looking at some of these changes. This is, I thought, a really good example where you can see pericardial space up here, right ventricular free wall, septum, and you can see how the septum moves up during expiration. And then when the patient inspires, it moves back down and the right heart's a little bigger there. So I thought that was a very good example of documenting the septal shifting that we see. And then the real key earmark is the respiratory flows. And for that, again, you want a slow sweep speed. If you can, document respirometer. If you can, try to annotate on the screen when the patient's breathing in and out. This is a good representative right heart where you can see inspiration starting here. So the first full diastole, you want to measure the E wave. And then expiration starting here, the first diastole. I know there's a cursor here, but typically measure this one here. You are going to see respiratory variations on the right side of the heart in normal people. A small amount of variation is considered normal. So that's why on the right side, you typically want to see 25% change or greater for it to be considered significant. On the left side, left side's changes are usually more specific, or more specific to hemodynamic compromise. Typically, we're not going to see changes in normals as often, and you really only need to see about a 15% change on the left-sided filling with respiration for that to be considered significant. On this example here, again, inspiration, the first full diastole after that, the E wave is down here around 0.4. After expiration starts, you're looking at about 0.8. So a very significant change on this one. So here's another example. This is the same patient, both looking at the tricuspid and mitral valve inflows. Again, you really want to get both. Again, the mitral is going to be your more specific marker for that. But here, inspiration starting here, flows about 0.8 meters per second, and expiration is much less. So very significant changes on the right side. Again, also very significant changes on the left. Inspiration here, we get 0.4 meters per second. Expiration about 1 meter per second. And then another example here, again, same patient looking at inflows from both tricuspid and mitral sides. This one's not as pretty, but this is, this is oftentimes what we get. Inspiration, and you see the first E wave of inspiration is quite a bit higher than expiration, which is going to be down here. And then milder changes on the left side, which is common, but still significant. Another thing that you can look at, and this is looking at outflows as well. And this is really helpful if patients have difficult apical views or there's so much cardiac motion, it's really hard to get consistent tricuspid or mitral inflows throughout the respiratory cycle. You can look at the pulmonic valve and the aortic valve as well. One thing to remember though is it's going to be a little later delayed because in this view here, inspiration starts here, but the first full diastole is here, so that really the first outflow after that first inspiration diastole is going to be this long way from here that's measured. On expiration, again, expiration starts here, but the first real diastole, full diastole is going to be here, so you'd want to measure this one. So even though this looks to be, this and this look to be the first beats of inspiration expiration, you have to take into account when does diastole occur. And same true with this aortic valve that we're looking at. Inspiration begins here. You want it, but the first diastole is going to be here, so you want to measure this. And again, expiration begins here. Here's going to be the first diastole, and we measure this one here, and then compare those two. All right. Hepatic vein flow. So again, you're going to find the same kind of things with hepatic veins that you'd see on the right side filling, not surprisingly. On inspiration, more forward flow. On expiration, you're still typically going to see forward flow in systole, but you'll see reverse in diastole. And so this is a very classic kind of sign of hemodynamic compromise seen in the hepatic veins. This one's a little more significant in that you really only see inflow towards the right heart in inspiration and pretty much lack of flow in expiration. And then chamber collapse, which is really kind of at the far end of the spectrum of the hemodynamic compromise. This is really towards the tamponade side of things. And again, this is a great example of a right atrial collapse, but it's a very short clip. It would have been much a better clip if we had taken quite a few more beats. You can really see the change over time. Again, here you can see right atrial collapse occur. The right atrial free wall just completely inverts during expiration. Okay. And again, M-mode can be a great way to look at that. Here we have this with respirometer. Again, you can see atrial wall coming in consistently with atrial systole, but the diastolic profile of the wall is different in expiration versus inspiration. And that's really a kind of key marker. You do want to kind of weed out atrial systole versus collapse due to respiratory variation. So for pericardicentesis, I want to talk about this real quick. Looks like I'm kind of running out of time here. We do like to measure kind of the depth from the probe to the effusion, and then also the separation of how much effusion there is from the parietal to the visceral layer. So basically showing the interventionalist how far it is to the fluid and how much separation they have before they would hit a cardiac structure. We like to do these measurements in supine position. So if we have the patient left lateral for the majority of our imaging, oftentimes we'll lay them supine and get these additional measurements before we end the study. Almost all of our pericardial centesis done at our institution are done with echo guidance. So we will go down the cath lab, typically get out of the same patient at the same time the patient arrives, so that we do our imaging prior to when the patient gets draped. We can then image the patient on the table in that position, show the interventionalist where the fluids are, what the approaches are. They can make their decision as to which approach they want to take, and then they can prep that specific area for the procedure. The other thing that we'll do when working with interventionists is show them exactly what the angle of the transducer is, both off the horizontal and kind of either towards midline or out laterally. So they can see that if they want to mimic what we're seeing, that they would have to have a similar angle approach. Oftentimes our interventionists will even take the probe in their own hands so they can really get a feel for what that angle is, where between the rib spaces we're shooting between, and really try to mimic kind of our probe angulation with their needle angulation so that they can get into the fluid. Another thing that we oftentimes do in the cath lab is the interventionalists will, once they get into a fluid pocket, inject some agitated saline so that we can make sure that they are in the correct space. This is really helpful for patients that have both pleural effusions and ascites because they may be in an adjacent space and not realize it. So the presence of agitated saline through the needle into the pericardial space definitely confirms that they're in the right area. So this is obviously a subcostal four-chamber plane, and you can see saline filling the pericardial space there. Apical four-chamber view, which kind of comes in and out of respiration, but again, you can see the pericardial space filled with agitated saline. And then lastly, one other use we've been able to have with the interventionalist is for perforations. Whether it's a coronary perforation or potentially a perforation through a cardiac chamber, we are oftentimes called down to look for the presence of an effusion, but we'll oftentimes use not contrast, but echo enhancing agents like Definity or Optisong to see if there's a communication between the chamber or the coronary artery and the pericardial space. So this was an EP procedure where they were putting a lead into the right ventricle. You can kind of see that the lead looks to extend through the myocardium of the right ventricle and into the pericardial space. There is a small pericardial effusion here. So we had Definity injected into the patient, and you can actually see a little bit of the Definity out here into the pericardial space, showing that there is still a communication between the right ventricle and the pericardium. Okay, well, that's all I have. I really hope you found this useful, and really appreciated being able to present to you all. Vietnam looks like an absolutely beautiful country. I've heard people that live there are amazing. I'd love to come visit sometime, and would love to have any that are interested to come out to Washington State in the US and come visit us. But again, thank you very much. Have a great day, and thanks again. Bye.
Great. Well, we really appreciate that overview of the pericardium and particularly pericardial effusion from Todd Zwink. As I mentioned before, he has a wealth of experience. Very happy that he could give us these very practical tips. Well, next up, we're going to have Associate Professor Nausheen Akhter from Northwestern University in Chicago, Illinois, give us the next talk. Nausheen is an expert in cardio-oncology, and basically what that is, for those of you who don't know, is in taking care of patients who are receiving cancer therapy but develop heart problems or are at risk for heart problems. She is a great educator. She's received a number of impressive teaching awards while being on faculty at Northwestern, and she is a member of the American Society of Echocardiography Foundation Board of Directors. We're very, very glad to have her give our next talk.
Thank you again to the conference organizers for the opportunity to speak on a favorite topic, strain imaging. My name is Nosheen Akhtar, and I'm an associate professor of medicine and the director of cardio-oncology at Northwestern Feinberg School of Medicine in Chicago. I have no relevant disclosures for this presentation. So let's kind of step back, and in order to understand strain, we must start with an overview of the cardiac architecture. Myocardial fiber orientation is in an orderly fashion from the endocardium to the epicardium. The endocardial fibers run in a longitudinal fashion, while the mid-myocardial fibers run in a circumferential fashion. Fiber direction changes from a right-handed helix in the subendocardium to a left-handed helix in the subepicardium. Myocardial contraction propagates in an orderly fashion along the myocardial band, which starts at the pulmonic valve. The base moves towards the apex down a descending loop in a clockwise direction, and then the apex moves towards the base in an ascending loop in a counterclockwise direction. The entire LV and RV consist of a single myocardial band that is wound up like a turban. When unraveling the heart, we see this beautiful, complex relationship of the myocardial fibers that results in two opposing helices that result in contraction. The AAC definition for cancer therapy-related cardiac dysfunction is a decrease in LV ejection fraction by greater than 10% to a value less than 53%. Please note that this definition does not include strain, and that cancer therapy-related decisions should not be based on strain. So what are the limitations to LV ejection fractions? Well, subtle changes in LV function may not be detected by EF, and image quality and precise endocardial border definition may be problematic, particularly in our cardio-oncology population, like breast cancer patients who've had a mastectomy, radiation, or have breast expanders or implants. There's an inability to oftentimes visualize the true LV apex. Loading conditions, contraction and expansion can affect the LVEF, and there's measurement variability. So what is strain? Strain is a tool that we can use to characterize myocardial deformation. While motion cannot distinguish between active and passive motion, but deformation can distinguish. And strain is not affected by translational motion or tethering. Strain is expressed as myocardial deformation is expressed as strain. It is the total deformation during the cardiac cycle relative to the initial length of onset of the cardiac cycle. It is a dimensionless number and expressed as a percentage. Strain rate is essentially strain over time. In this cartoon depiction, you see that the percent change in the length of the myocardium during relaxation and contraction over the initial length. There are two methods to obtain strain. Tissue Doppler strain, which is angle dependent, used primarily for longitudinal strain, and there's no retrospective application. There's an inter-observer variability between 10 to 15%. Since tissue Doppler strain is a single dimension, the alignment of the ultrasound beam with the wall is important, and there are limitations with this if the measured velocity, which is depicted here in yellow, is not aligned with the wall. The velocity obtained may be underestimated. In order to overcome this, the sonographer can narrow the sector and acquire a single wall acquisition that will decrease the angle of incidence. However, we more often now simply use speckle tracking strain. Speckles are seen in the natural, in the myocardium as sort of natural acoustic markers that are distributed throughout heart tissue. And automated software can be used to essentially look at the displacement of the speckled pattern. It is angle independent, provides longitudinal, circumferential, and radial strain. There is a retrospective application, and the inter-observer variability is between 7 and 11.8%. There are three primary strain vectors, which you can see here. The longitudinal vector, as well as the circumferential vector, which is obtained on the short axis image, are both at negative values. The radial strain, which represents the thickening of the heart in the short axis view, is shown here. It is a positive strain value. There are several factors that affect strain, several hemodynamic factors that are critically important to think about in our patient population. If there's hypovolemia, that can lead to reduced strain. If there's hypertension, that can also lead to reduced strain. New or worsening changes in the cardiac geometry with increase in LV size and dilation, which sometimes we can see with anthracycline agents, can reduce strain. Personal cardiovascular risk factors and prior cardiotoxic treatments must be considered. So how do we obtain GLS? Well, it's obtained in a stepwise manner. After image acquisition of appropriate images, you define the aortic valve closure so that we can define systole, mark the mitral annulus and apex, and trace the endocardial border, adjust the region of interest, and assess and approve the myocardial tracking. In order to optimize strain, we obtain our three long axis images of the apical 4, 2, and 3 chamber at the end of the study to ensure similar range of frames per second. Frames per second should be between 40 to 90 frames per second and acquired at a minimum of 3 cardiac cycles. And always remember to document the blood pressure. Narrowing the 2D sector width to include the entire LV myocardium and the LA base is important. Do not cut off the walls in systole and diastole. That will affect strain. A lower frame per second can also lead to undersampling, and loss of speckles, which can affect the strain. When the automated tracking verification does not fit with your visual inspection or impression, adjust the region of interest to optimize the tracking and include as little as possible outside the region of interest. Do not include papillary muscles or the pericardium. Remember that foreshortening an image can affect the strain values, and improper aortic valve closure or timing can affect the strain values. If the 2D image is of poor quality, do not attempt the strain. This was a nice summary of the strengths and limitations of strain in JACC cardio-oncology that is online, with some online examples of how to optimize strain, and I would encourage everyone in this audience to review it. Strain is highly dependent on image quality and windows. Post-processing is also dependent on operator skill, which does improve with experience. There are different vendors and software which can affect the strain values, and this is being addressed by the ASC Standardization Task Force. This was a meta-analysis published in 24 studies in about 2,500 patients, and here you see the normal ranges for GLS, GCS, and GRS. When reporting strain, it's important to review all of the strain curves for accuracy. Report the average and systolic GLS. You can report both an absolute on-treatment GLS in our oncology population, as well as a relative change in GLS from baseline or pre-chemotherapy. Describe any changes in strain patterns in your report and capture a frame of the strain curves and the polar map or bullseye plot on every study for the physicians to review. We published this review in JAMA Cardiology on the diagnostic and prognostic value of strain, looking at the bullseye plot. And here we show some examples of changes on the bullseye plot based on different ischemia territories. And over here, some examples of a patient with apical Takotsubo, apical ballooning Takotsubo, and reverse Takotsubo cardiomyopathy variants. Strain is also very important for the evaluation of left ventricular hypertrophy, and on top it is an example of the classic cherry on top that we see in patients with cardiac amyloidosis, and on the bottom 2 examples of patients with hypertrophic cardiomyopathy with septal hypertrophy and with apical hypertrophy. So what is the role of strain in cancer therapy? This is kind of going to be the focus of this presentation. see here that strain is especially useful in those patients with a normal to low normal ejection fraction. In this group, strain can be used as a second objective marker for cardiac function. The question is, what do we do with this information, and how should we treat these patients? Should we be treating that number? Currently, we optimize risk factors and maybe consider closer surveillance. Starting cardioprotective therapy is being evaluated and is an active area of research. Let's present a case. This is a 72-year-old physician with AML. His pre-chemotherapy comes to you for a pre-chemotherapy cardiac risk assessment. The baseline LVEF of 65%, exercises regularly, no cardiac symptoms, is planned to undergo standard induction treatment with 7+3 or daunorubicin, a total dose of 180 milligrams per meter squared. He has some risk factors for cardiovascular disease, including age, hypertension, hyperlipidemia, but is a never smoker and there's no family history. His baseline global longitudinal strain is reduced at negative 14.7%. This is a very nice editorial that was published by in JACC Cardio-Oncology, written by Dr. Lopez Matei, which discusses the idea of a baseline GLS, which can be used to identify the vulnerable patient, and may be used to identify patients with baseline comorbidities or reduced contractile reserve. So should we really be thinking or considering these patients as having the equivalent of ACC-AHA heart failure stage B? The prognostic value of baseline global longitudinal strain has been demonstrated in hematologic malignancies. And this study done by Dr. Scherer, Crosby, and colleagues demonstrated the value of baseline GLS in patients with leukemia and lymphoma who were treated with anthracycline and followed for 4 to 5 years. They found a 6% cardiac event rate. The risk factors that were primarily seen were diabetes and hypertension. And what they were able to demonstrate was that a cutoff baseline of less than a negative 17.5% was associated with a 6-fold increase in cardiac events. They then went on to develop a risk score in their acute leukemia patients who were treated with anthracycline, incorporating in this risk for not just clinical parameters, but echocardiographic parameters such as LVEF and GLS, baseline GLS. And what they were able to show was this risk score was able to separate patients that into groups of high, moderate, and low risk for developing heart failure. And we did a retrospective validation looking at a cohort of 204 patients with AML with a 21% hospitalization for heart failure, and demonstrated that there was a significant association between heart failure and these risk group categories when employing the risk score. GLS has been primarily studied in malignancies employing anthracycline and trastuzumab. This was a very nice meta-analysis published in JAMA Cardiology, which demonstrated that both the on-treatment GLS and the relative change in GLS had good prognostic performance for subsequent cancer therapy-related cardiac dysfunction. They also showed that the discriminatory accuracy of GLS was consistent across cancer subtypes that received anthracyclines and trastuzumab. The authors warned, however, that there was limited data on optimal cutoff values and that we need large prospective studies. There was also some concern for publication bias. Turning back to our patient, our 72-year-old physician with AML, after induction, an echo was obtained that demonstrated sort of a low normal EF at 50 to 55%. His post-treatment course was complicated with by a colon abscess that required exploratory laparotomy that needed a sigmoid colectomy and colostomy. So the post-chemo sort of pre-op echo demonstrated this low EF, and GDMT was not initiated at this time due to hypotension. The post-induction GLS was lower at negative 11.5%. 5 months later, he wakes up with shortness of breath and is admitted to an outside hospital with new onset heart failure. The echo demonstrated an ejection fraction of 30%, elevated BNP and troponin. He was optimized with diuresis and started on GDMT. A left heart cath was obtained, which demonstrated non-obstructive coronary artery disease. He also had a cardiac MRI, which confirmed moderate LV enlargement and LVEF of 22%, normal RV size with moderately reduced RV function. There was no edema or scar. However, there was evidence of myocardial delayed enhancement in the basal infralateral wall, which was a nonspecific finding for remote myocarditis. 3 years into survivorship now, his ejection fraction continues to be mildly reduced. He's mostly sedentary, but denies heart failure symptoms. There were several papers published between 2011 and 2013 which demonstrated the prognostic utility of GLS and cancer therapy-related cardiac dysfunction. And these papers were the backbone for the current ASC consensus statement document. Of note, all of these papers were done on HER2-positive breast cancer patients that received sequential therapy with anthracycline followed by trastuzumab. Dr. Sherrera Crosby and colleagues were the first to demonstrate that monitoring GLS by spectral tracking could identify patients at risk for anthracycline cardiotoxicity, and that these changes in strain predated changes in LVEF. So strain is an early predictor of cardiotoxicity, and it has a very high negative predictive value across studies. And another study looking at 135 patients with breast cancer demonstrated the changes in longitudinal strain did precede changes in circumferential strain, which occurred later, and that these changes may affect our duration of heart failure therapy. The concept of subclinical LV dysfunction was defined in the 2014 AAC consensus statement as a relative change in 15% from baseline GLS in patients that did not meet the criteria for cancer therapy-related cardiac dysfunction. So with that, let's talk about another case. This is a 48-year-old female with left-sided breast cancer. She is ER positive, PR negative, and HER2 negative, diagnosed about a decade ago in April 2009. At that time, received a bilateral mastectomy with adjuvant ACT, which included adriamycin total dose of 240 milligrams per meter squared, cyclophosphamide, and Taxol. She had bilateral implant reconstructions and then was given adjuvant tamoxifen. Unfortunately, she is found to have a new primary of the lateral aspect of her left breast reconstruction in July 2018, and this time the tumor marker is positive for HER2. So she undergoes a wide excision, including skeletal muscle with negative margins, and is started on TCHP, which is docetaxel carboplatin, trastuzumab, and pertuzumab, which are both anti-HER2 agents. This is her baseline echo. So this is her baseline echo before starting the TCHP regimen. Her ejection fraction is 70%, GLS is a negative 20.2%, both in the normal range. At her 3-month echo, surveillance echo, or EF is reduced now to 58%, but still in a normal range, and the GLS is reduced to negative 16.3%. This is consistent with our definition of subclinical LV dysfunction. I think this is a good point to discuss the SECURE study, which was published this past year in JACC. The SECURE study was an international multi-center study, including 28 sites. 331 patients were randomized to either GLS or EF, and there was a low dropout rate between the arms. This study included a high-risk patient cohort, and most of the patients enrolled were treated with anthracyclines. Most had HER2-positive breast cancer, so they had received a sequential treatment with anthracycline followed by trastuzumab, 88% of patients. There was also high rates of cardiovascular risk factors, so 29% had hypertension and 13% had diabetes. Their primary endpoint was a 3D ejection fraction at 1 year. And the criteria for CTR-CD differed whether you were in the EF guided arm or the GLS guided arm. For the GLS guided arm, a greater than or equal to 12% change in a relative reduction in the GLS from baseline to any time point at follow-up was a considered criteria for GLS dysfunction, GLS guided cancer therapy related cardiac dysfunction. At the 1 year follow-up, the primary outcome was not different between arms. However, there was significantly greater use of cardioprotective therapy, with fewer patients who met the cancer therapy-related cardiac dysfunction in the GLS-guided arm than the EF-guided arm. And those patients who received cardioprotective therapy in the EF-guided arm had a larger reduction in the LVEF in the follow-up than the GLS-guided arm. So GLS-guided arm, the changes in EF were smaller, and there was a greater use of cardioprotective therapy. Cancer therapy was there was no difference between interruption or discontinuation of cancer therapy between arms, and there was only one clinical heart failure in both arms. So let's turn back to our patient who has had a subclinical change in her global longitudinal strain. At 5 months now, her ejection fraction has dropped to 47%, and her GLS is negative 14.7%. She endorses some shortness of breath with stares and chest tightness, so chemotherapy is held, and she started on carvedilol. GDMT is limited, again, due to hypotension. A stress test is done due to a prior history of left-sided radiation about a decade prior, which demonstrates no ischemia, and actually her ejection fraction then is improved to 50 to 55%. It is determined that she can now be re-challenged with anti-HER2 therapy, and she is switched to a different agent, TDM1, which is ado-trastuzumab. This is a newer, less cardiotoxic agent. Many of the newer anti-HER2 therapies are less cardiotoxic than trastuzumab. And is noted that LV dysfunction occurs in up to 2% of patients on ado-trastuzumab. At her 7-month echo now, after being re-challenged on ado-trastuzumab, her EF and GLS remains stable at 54% and negative of 15.9%. At 11 months, we see kind of this interesting polar map with red in the middle and blue on the outer edges of this bullseye plot. And what this bullseye plot represents is actually a breast implant artifact. You can see here that the shadow that from the implant that crosses across the base of the heart causes poor tracking in those segments, which then leads to this appearance on the bullseye plot. So we thought, well, this strain imaging can be very difficult in our breast cancer patients, due to radiation, tissue expanders, and breast implants. Is there a better way to follow strain in these patients? So we sought to evaluate the feasibility of the left ventricular longitudinal strain from the subcostal view, or subcostal strain, and our protocol was published in JACE. And the aim was really to look primarily at feasibility of a 3-chamber and 4-chamber longitudinal strain from the subcostal window and compared to the apical windows. We looked at 68 patients with breast cancer at various stages of chemotherapy that were analyzed, and we did find that there was good feasibility in left ventricular longitudinal strain, and there was a high degree of reliability and good agreement between the apical and the subcostal measurements for both 3-chamber and 4-chamber views. Post-treatment GLS has also been looked at to predict LV recovery in breast cancer patients, and in this study, GLS at the time of cardiotoxicity diagnosis was associated with the subsequent recovery. So those patients with a higher GLS, their cutoff in this study was greater than or equal to 15.8%, identified patients who had reversible cardiotoxicity. Some novel applications for strain and anti-cancer therapies has been looked at. We discussed yesterday that with ICI myocarditis, greater than 50% of patients can have a normal ejection fraction, and that's led to the question, can GLS be useful in these patients to help identify patients that develop myocarditis? And this study was led by Dr. Tom Nealon and colleagues that looked at the utility of GLS in patients with clinically suspected ICI myocarditis. It was a retrospective multi-center study that found that The lower GLS by echo was predictive of MACE in both patients with normal as well as reduced ejection fraction. What about other cancer therapies? Well, GLS has been looked at in VEGF inhibitors, such as sunitinib, pazopanib, and bevacizumab or Avastin. This study was done by Dr. Mulvag and colleagues that looked at 40 patients at 2 centers, and those patients had a metastatic renal cell or colorectal cancer. And that they prospectively obtained an echo at baseline at every 3 months for the first 6 months. 8% of patients developed an asymptomatic decline in LV function. However, 30% of these patients had a decrease in GLS, and an abnormal baseline GLS also was found to increase the risk for cancer therapy-related cardiac dysfunction in this group. Ibrutinib is another medicine that is given to patients with B-cell malignancies such as CLL, which has been shown to increase the rate of a risk for atrial fibrillation. It's in a range of about 10% of patients treated with ibrutinib. And so we hypothesized that left atrial strain in the pretreatment echo may be able to identify patients who are at risk for atrial fibrillation on ibrutinib, and looked at 66 patients who had a pretreatment echo. 22 of these patients went on to develop AFib on ibrutinib. These patients were older and had more comorbidities. On their baseline echo, there was also an elevation in E over E prime that was increased in those patients who developed AFib. Now, recall that left atrial strain has 3 components to it. There is the left atrial systolic peak strain, which is also known as the reservoir function. And then there is the atrial component, which is the booster strain. And the difference between the reservoir and booster strain is the conduit strain. As you can see here, the panel on the top represents a patient with on ibrutinib who did not develop AFib, and on the bottom, a patient on ibrutinib who did develop AFib. And what we were able to show was that there was an impairment in the booster strain that identified patients with poor atrial contractile dysfunction, poor atrial contractile function, which predisposed them to develop the ibrutinib-related AFib that was independent of age. We've talked a lot about LV strain, but RV strain is also an important parameter to monitor in patients treated with anthracycline. And this cohort of patients with diffuse large B-cell lymphoma receiving R-CHOP were assessed at baseline and that after every 2 cycles until completion. And we found, and these authors found that in 74 patients undergoing treatment with 6 cycles of R-CHOP, that after cycle 2, which was actually 4 cycles, there was evidence of RV dilation with decrease in RV free wall strain, and that at completion of treatment that resulted in a decrease in RV function. So in summary, it's important to contextualize global longitudinal strain interpretation based on the cardiac condition. For cancer therapy, it is important to know the time point of the echo during treatment and the treatment history or regimen. It's also important to look at the strain pattern on the bullseye or polar map. And this is a very important diagnostic tool that we should be utilizing. Pre-treatment global longitudinal strain can also identify patients at risk for cardiotoxicity, especially those with leukemia and lymphoma. And absolute on-treatment global longitudinal strain and the relative change in global longitudinal strain from baseline can be used for prognostication on anti-cancer therapy and has been shown most useful in cancer subtypes that use anthracyclines plus minus trastuzumab. SAKUR demonstrated that global longitudinal strain surveillance detected more cardiotoxicity than EF surveillance, but that the final EF at 1 year was no different between these 2 groups. And there are lots of opportunities here for future research in studying strain with novel cancer therapies, investigating GLS cutoffs throughout the cancer care continuum, and looking at the utility of left atrial strain and RV strain. Thank you again to all of you, and congratulations on a fantastic meeting. Hopefully we can all come together again soon in person.
Well, that was wonderful. It's a very important topic. I should ask Dr. Wai, how much of your business in echocardiography actually deals with cardio-oncology?
Thank you very much for your important question. I must accept that we haven't done as much as we want in cardio-oncology. I think it's partly because of the organization, how to organize the system. Because in like my hospital, for example, the cardiology department is separate from the oncology center, and in other center we have different and isolated cancer center, so it's not very convenient to send the patient between the hospital, especially when the patient is very sick. We do echo for patients with cancer and chemotherapy, but we often do pre-chemotherapy cycles and after the chemotherapy cycle. But within the cycle, the patient are very sick, and then the system are not good enough to transfer the patient between the hospitals. Thank you. I think we need to set up a cardio-oncology unit within the center for oncology.
Well, thank you for that answer. And that is why we're having sessions like this at this Congress. Very important to consider this. I will tell you that we have similar challenges. Our cancer center is different. The hospital, the cancer hospital, is the same as our hospital, but the outpatient cancer department is quite a ways away. And we have been talking for a long time about setting up an echo lab there so the patients don't have to come to visit us, but it hasn't happened yet. So I think we're all learning about this together, and we appreciate so much Dr. Akhtar's expertise, and I'm so thankful that she was able to educate all of us about this important topic. Well, next up we have Dr. David Linker. Dr. Linker has been to Vietnam in the past, and he has experienced the wonderful hospitality. He has also been one of the people who has been a great host of clinicians from Vietnam who have come to the University of Washington. We really appreciate his talking today on this important topic of transesophageal echocardiography. I want to mention that Dr. Linker has a book on the topic of transesophageal echo coming out in January. So he is, of course, a true expert and has some excellent insights to share with us, particularly about the practical tips for an effective transesophageal echocardiogram. Thank you so much, Dr. Linker.
Well, thank you. Thank you so much for that wonderful introduction. Let me just mute my sound here. So does that sound okay now? Okay. Thank you so much for the organizers for inviting me to speak about practical tips for an effective transesophageal echocardiogram. I think that learning an echocardiogram is a lifelong task. And what I'd like to emphasize is some tips that are not obvious when you start doing an echocardiogram. These can be organized into facts. These are the structure of the probe, the physics of ultrasound, the anatomy of the patient. And then we'll talk about how these impact the examination itself, how they impact how we insert the probe, how to move the probe, how to get the best pictures of a structure. First, some discussion of the names of the parts of the probe. We need to know our tools. So we have the control handle, which is where the controls are. Then we have the body of the probe, which is obviously very long, so it's been shortened here. Then we have the flexible tip, and then at the end is the transducer. If we look closely at the transducer, we notice something right away. It is not symmetrical. It's not round. It is flattened. So on the left, we have the actual transducer face. Then we have a side view, and then we have the back side of the transducer. So right away, we understand that this is not a symmetrical structure, and we should take this into account when doing a transesophageal echocardiogram. So the fact to remember is that the transducer tip is flattened. So why does this matter? If we look at a laryngoscopic view of the larynx, then we can understand this. And so this is an actual view of the human larynx with a patient prone, and we are looking as if we are looking down into the larynx. So we can see the epiglottis on the bottom, the trachea in the middle. We see one of the piriform fossae on the left, and there's another one on the right, which is not labeled, but there's a sort of change in coloration at the top. And that slit is the esophagus. So that is what we're trying to aim for. So it's very clear that if we just put the probe in, it will go to this very inviting trachea that's right in the middle, as opposed to towards that esophagus, which is a potential opening at the top. So if we're inserting the probe, since it is flattened, it's best to align it with that slit of the esophagus. If we have it oblique, then it's less likely to pass easily. So the fact to remember is that the esophagus is a slit. The next is to notice that, oops, sorry. My video is not running here, sorry. So the next point is to notice that the transducer does not flex uniformly at the tip. The tip of the transducer is rigid, and there's the flexion is about 5 centimeters behind the actual transducer tip. So the fact to remember is that the flexile tip is rigid, flexing about 5 centimeters from the end. Sorry, there was a problem with the transition there. The next is that the body of the probe itself is torsionally rigid. So if we look at the top image, then if we have the probe extended, then the probe will move along with the control handle. If we try to rotate it by grabbing it where there's the red X, it won't rotate because the probe is torsionally rigid. So in that situation, it's much better to rotate from the control handle. In fact, that is the way the probe is designed to be used. If we have a loop, as illustrated on the bottom, then there is some flexibility, and with difficulty, we can rotate it at the tip, as illustrated with the yellow arrow, but it's not as easy as if we have the probe extended and rotate from the control handle. So the fact to remember is that the body is designed to rotate as a unit when extended. We can make a choice about whether to keep it extended for maximal control, or realize that if we allow a loop, there will be some difficulty in rotating it from the tip. The next is involuntary rotation due to the rigidity. So in these diagrams, what I've done is I have moved the probe by just actually I've just moved the control handle towards the tip. And you can see that the tip rotates even though the control handle is kept in the same orientation. And so this is a problem, because that means that if there's a loop in the transducer, or excuse me, the body, that we have no idea where the transducer tip is oriented during insertion or while we're doing the study. So the fact to remember is that the body is stiff and can rotate involuntarily if there's a loop. The choice to make is to keep it extended for maximal control or realize the possibility of rotation if we allow a loop. So why does this matter? As we're inserting the probe, remember that we want to keep the probe tip aligned with the esophagus. If we allow a loop in the body, then there will be an involuntary rotation of the tip, which we will not be aware of because the tip is hidden from us, and it may be more difficult to pass the probe. Again, the solution is to keep the body extended, and that way we can keep the tip aligned. When we insert the probe, then we have to pass the curvature in the back of the oropharynx. If we just insert the probe extended straight, we'll just hit the back of the oropharynx, and that is not something we want to do. We need to find some way to bend the probe to go towards the esophagus. One way is to press down on the probe using our fingers. And this is illustrated here with these red arrows. It's just a gentle pressure as we're inserting the probe if we have our fingers in the mouth. Another approach is to put some curvature on the probe tip and to gently insert it with holding that curvature. Now, that can work, but if the curvature changes while we're inserting it, then it may not work as well. My preferred way of doing it is to intentionally flex the probe as I'm inserting it, doing a coordinated flexion during insertion. And that's illustrated in this short video. So the problems we've talked about so far and the solutions. The first is that the probe feature is that the transducer is rectangular. And that is an issue because oblique insertion is difficult. The solution is to align the transducer horizontally to the esophagus. The next feature is that the probe tip is rigid. And that means that there's flexion only about 5 centimeters from the tip. And the solution is the different insertion techniques we just discussed. The next feature is the rotation of the probe with loops. And that is that the probe involuntarily rotates if there's a loop. And the solution is to avoid a loop of the probe body. The next probe feature is the torsional stability of the body, which means that it resists rotation. The solution to that is to rotate from the control handle. So next we'll look at navigation motions of the probe. Moving the probe can be very challenging when we're learning transesophageal echo because there are 5 different types of motion. And the question is which motion to use at what time. There are 3 of those motions which are primarily for navigation. And these are illustrated here. Those are withdrawal and advancement of the probe, rotation of the probe, and anteflexion and retroflexion. Now, note that when we're withdrawing and advancing, the motion is aligned with the sector alignment when the sector is at 90 degrees. So that means that if we put our sector at 90 degrees, we will very easily be able to see the corresponding motion that we should do to change the image. Similarly, for rotation, it's aligned with the sector at 0. So it's optimal to have the sector at 0 when we're doing a rotational motion. For the anteflexion and retroflexion, it's also aligned with the sector at 90 degrees. So that if we're at 90 degrees, we can easily understand what the effect of that motion will be. So generally, we want to align the sector to the axis of rotation or motion that we're using for navigation. The other types of motion are changing the sector angle and lateral motion of the probe. these are primarily for optimizing the image as opposed to navigation. In fact, if we have our sector at an oblique angle, it can be challenging to figure out what motions we should be making to optimize our images. So I recommend that you choose 0 or 90 degrees as a sector angle when you are trying to navigate to a structure, and then change the angle to optimize the image after that. So a summary of our probe motions. We have 3 motions that are primarily for navigation and 2 that are primarily for optimization. In terms of navigation, one note about advancing and withdrawing is we should not advance the probe when the probe is flexed, because this can risk prolapse of the probe. In rotation, it's most comprehensible when we are at 0 degrees sector angle, and antegrade and retroflexion are most coordinated with the advancement and withdrawal. Sector angle is mainly for optimizing the image structure after we found it, and lateral flexion is rarely used, but mostly used when there's a limited echo window and we're trying to use the lateral motion to get better location relative to the echo window. So the fact to remember is that the primary axis of motion are aligned with 90 degrees and 0 degrees sector angle. So if we align the sector angle to those axes when we're making that motion, it will make things a lot easier for us. So the choice to make is what sector angle we should be using when navigating to a structure. So a template to consider when for moving to a structure is what I call by the acronym AMP, for angle, move, and picture. That is that when you're done with looking at one structure and you're about to go to another completely different structure in a different part of the heart, then you should change the angle to the either 0 or 90 degrees, depending upon what is best to find the next structure. It's often seems easy just to be stay at whatever angle you're already at, but it actually saves time and effort if you move to the best angle before moving. Then you move to the probe to find the next structure of interest. And once you're there, then you optimize the picture by placing the structure in the middle of your sector and reducing intervening structures, as we'll discuss in some subsequent slides. So just remember the acronym AMP. So another point is that there are echo windows, and there are limited places where we can see the heart when doing a transesophageal echo. Now, sometimes some patients have very large echo windows, and sometimes patients have very small echo windows. But even being aware that there is an echo window, and then having strategies for finding the echo window, optimizing the echo window, and locating where you should be in it are helpful. So the most used echo window is the mid-esophageal echo window. And that's where we get most of our images. There's also a high esophageal window, which is often not used, but useful for the pulmonary artery and ascending aorta. And then there's the gastroesophageal junction window, the transgastric window, and the deep transgastric window. Now, when you're using a particular window, like in this case, the mid-esophageal window, it's helpful to realize that it is limited in its extent and optimizing where your transducer is compared to where the window is. So in the diagrams on the top, we have the echo window in the colored pane. And then we have the transducer, which has different locations relative to the echo window. In the panel on the left, the transducer is right at the lower edge of the echo windows. I should say that this is, the diagram is as if the patient is prone and their head is to the right. So what we can see, if we look at the image on the bottom, notice how blurry it is on the left side of the sector. Now, this is with the sector angle at 90 degrees, so it's aligned with the motion of the probe. what that tells us is the transducer is right at the bottom of the echo window. So then if we pull back, as shown in the second center panel, all of a sudden the inferior wall of the heart is much clearer. But we knew that was going to happen because we can see that that's the reason it's unclear, and we know exactly which direction to move in and how to correct that problem. On the right, we've gotten to the top of the echo window, and the images on the right-hand side of the sector have become very blurry because we're at the edge, the upper edge of the echo window. So this is a way you can use orienting the sector angle with the axis of motion of the transducer and a knowledge about the echo windows to optimize your image quality. Another point is that the image quality is not the same across the sector. So if we have a structure at the side of the sector, it will be more blurry than in the middle. And that's illustrated, the reason for that is illustrated with this simulation. So these are simulated beams of a 1 centimeter transducer, 5 megahertz, 5 centimeter focus, simulated out to 10 centimeters. So on the left, we have a beam that's right in the middle of the transducer, which is the optimal focus. On the right, we have the same transducer in a phased array that has been focused off to 45 degrees. And what you can see is the beam is much more blurry than on the left. Now, to make this a little bit easier to see, we'll take that beam on the right and we'll rotate it so it's pointing upwards. And so now we're looking at them in the same orientation, and we can clearly see that the beam on the right is much broader and has stronger side lobes than the one on the left. Now, this is based on the physics of ultrasound. So it's not manufacturer dependent or patient dependent. This is always going to be true, which means that always the image quality at the sides of the sector will be inferior to in the middle of the sector. If you start paying attention, you can see this on all ultrasound exams when you're doing them. And this is one where this is looking at the descending aorta. But if you look at the speckle pattern in the middle of the sector and compare it to the speckle pattern on the right-hand side of the sector or the left-hand side, you can see that the sides of the sector are more blurry than in the middle. And this is not coincidence or patient related. This is based on the physics of ultrasound. So what that means is you should always try to bring your structure of interest to the middle of the sector for optimal imaging. Now, there's another advantage of bringing the structure of interest to the middle of the sector, and that is that that is the axis of rotation when you change the sector angle. So here is an example of looking at the left atrial appendage, and the left atrial appendage has been brought to the middle of the sector, and then we start changing the angles. Now, what happens is that when we change the angle, the left atrial appendage is still right in our sector. If instead we had the left atrial appendage someplace elsewhere on the sector and we change the angle, it would disappear and we'd have to go hunting for it, which is not very effective. By putting it into the center of the sector, not only do we get better image quality, but we also save time because it doesn't disappear when we change the sector angle. So another point is that when we are looking at a structure, frequently it's helpful to examine the orientation before we try to look at it. So this is a view of the left ventricle at the mid-esophageal window at 90 degrees. And on the left-hand side, nothing has been done. The probe has just been placed there. We take the image, and that's the image. Now imagine that instead of looking at 90 degrees, we had chosen to start at 0 degrees, then the plane that we would have been looking at the ventricle through would have been the white arrow, and the ventricle would have clearly been very foreshortened, and there would be no way we could move the probe up or down that would make it correct. Instead, we can use the orientation that we see on the image on the left to do a gentle retroflexion of the probe, correcting for that tipping of the ventricle, and that's done on the right. And when we do that, we have the center of the sector is exactly aligned, so that if we then switched to 0 degrees, we would get a beautiful four-chamber view that was not foreshortened. So the next point in optimizing images is that we want to have as few intervening structures as possible. If there are any intervening structures, then there's a chance of reflection or reverberation artifact. Here's an example on the left panel of a reverberation artifact because from some probably lipomatous changes in the atrial wall, causing something that looks like there may be something in the left atrial appendage. Again, this is an image at 90 degrees. And so we can tell that if we advance the probe, we'll get a more favorable angle to look down into the left atrial appendage. And that's illustrated on the panel on the right, where we can clearly see into the left atrial appendage and that there's no problem there. Now, this is a video showing the same thing, but with a slightly different type of artifact. So in this case, there is a reflection artifact. And at the beginning of the video, it looks like there's a thrombus or maybe 2 thrombi in the left atrial appendage. And in this case, we're again at 90 degrees. And as we advance the probe, you can see the artifacts move and eventually disappear. Again, this is showing the advantages of aligning the sector with the motion of the probe, so we know exactly what move we should do to resolve this artifact, and then also the advantages of looking directly down into the left atrial appendage to avoid artifacts. So a few tips about optimizing image quality. If we're at the edge of the window, we get a hazy image. The solution is to move the probe to the echo window. If we're at the edge of the sector, we get a slightly blurry image. The solution is to bring the structure to the middle of the sector. If there are intervening structures, we can get artifacts, and we should move to have no intervening structures, to have a clear shot into the structure we're interested in. So to summarize, we've had a number of different tips on probe structure. We should try to work with the structure of the probe rather than against it. So it's designed to have torsional rigidity. We shouldn't fight that rigidity. We should actually use it to our advantage. So we keep it extended for best control of rotation. When it is extended, rotate from the control handle rather than from the tip. When inserting the probe, keep the tip aligned with the esophagus so that we have the easiest passage. If there is a loop, it can cause involuntary rotation of the tip. Remember, the tip is rigid and how that affects motion during insertion. In terms of probe motion, the first tip is to simplify your motions. That there are only 5 types of probe motions, but 3 are best used for the entire examination, and 2 are primarily for image optimization. When the sector angle is at 90 or 0, it aligns with the probe motions. When looking for a structure, choose a sector angle of 90 degrees or 0 degrees. This will simplify your life quite a bit. When use the sector angle of 90 to find the size and location of the echo window. Put the structure in the middle of the sector to make it the imaging after rotation easier. Some tips for optimization. Small changes that can make a very big difference. Align the structure correctly. Bring the probe into the echo window. Bring the structure to the middle of the sector. Find an unobstructed view if possible. So learning about echo is and transesophageal echo is almost like life. It's a lifelong task that is never done. And I found this quote, which I really like, which is to live a life full of humility, gratitude, intellectual curiosity, and never stop learning. This is from the rapper Jazza, but I think it's very good advice for life and for learning transesophageal echo and becoming better at it. Thank you very much for your attention.
Thank you so much, Dr. Linker. That was a tour de force of echocardiography from within the esophagus. Thank you also so much for your wisdom, not only about TEEs, but about life in general. And I love the fact that you were able to draw that very, very excellent connection between lifelong learning and learning about TEEs.
Yeah.
I do want to give just a few moments for myself and Dr. Y also to ask you a few questions about TEEs before we move on to our next presentation. In talking about using the TEE probe and actually inserting it is what I was hoping in particular. One of the things that I have found helpful in sort of getting after you get into the posterior pharynx is actually retroflexing a little bit to help it down. I was wondering if you could comment on that.
Oh, I agree completely. And I think that that image of the laryngoscopic view, the first time I saw that, I thought it was terrifying, because you see this huge trachea and vocal cords just inviting the probe. And it makes it very clear why you should do the gentle retroflexion, as you just mentioned. And I always tell the fellows just to do a very gentle retroflexion of the probe at that point. And I think that helps quite a bit. Another point is that it helps you understand a lot of the maneuvers we do. So for example, when we do the jaw thrust, when we have a patient that's supine, we're bringing the larynx a little bit anterior, which opens up the esophagus slightly. And just this week, I was doing a patient who was intubated, and I didn't pay attention to his head position. His head was slightly extended, and we were having a lot of trouble passing the probe. And when we just brought his head to a neutral position, we passed the probe the first time. And I think the combination of the endotracheal tube sort of an extension of the neck was slightly pressing on the esophagus, making it more difficult to pass the probe. So I think attention to detail is very important.
Excellent points. Dr. Y, any comments or questions?
Yes, thank you, David, for a wonderful, amazing presentation, which is very educational and bring us standard knowledge. I think it is the first time I have ever listened to this level of expertise in transesophageal echocardiography. And can you please advise on which view can be used to visualize the pulmonary valve? I find in my practical in my practice it is quite difficult for us to do the pulmonary valve.
That's a very good point. And so in my book, then one of the things I point out is the extreme variability of the RVOT and main pulmonary artery in terms of their orientation. And one of the problems that I had to overcome, and I think all of us has to overcome, was we have a mental model of what it's like. And like life doesn't care what our mental model is, it just is. And in my book, I have an illustration of the two different RVOT main pulmonary artery images that look almost identical. One was taken at 50 degrees sector angle, and the other was at 109 degrees. And so the point is that you cannot have a mental model. It's better to have an algorithm, a method for finding the pulmonic valve. And there are, I don't have time to explain, but there are two different approaches depending upon from the mid-esophageal window. There is an algorithm that I describe in my book in which a method for finding the optimal angle that's that makes it very, very quick to find what is the optimal angle. And then the other is that sometimes I send you privately a little excerpt for that. But then there's also the possibility of looking at it from the high esophageal window. And people often forget the high esophageal window because often it's not available. But I've had situations, especially even people with pulmonary conduits, where we weren't able to see anything from the mid-esophageal window. And we went to the high esophageal window and we could see the conduit beautifully and make a diagnosis.
Thank you, David.
Sure.
That's excellent. Well, let's go ahead and move on to our next presentation. And I have to give my apologies on behalf of Mr. Keith Collins. Keith is unable to join us today. He has had some challenges in family matters and was unable to do that. So, but he has very kindly sent his slides, which I will attempt to present. He is a sonographer, and in fact, the lead cardiac sonographer at Northwestern Medicine in Chicago. He is an advanced imaging educator specialist. In other jobs that he's had, he's been responsible for educating sonographers and physicians about advanced imaging techniques in echocardiography. He has been to Vietnam on several occasions, has participated in our outreach events. He's also been many other places in the world doing the same thing. And each time he not only scans, but also does a lot of work in actually presenting really excellent techniques, tips and tricks for using advanced techniques to image different cardiac structures. So without further ado, I'm going to go ahead and attempt my best to present his presentation here. And the presentation is really just going to focus on some of these techniques for looking at valvular structures using transthoracic echocardiography. And he took these slides, he made these slides primarily from two of the ASC guidelines that were put out. One is, you can see a while back in 2017, recommendations for non-invasive evaluation of native valvular regurgitation. But then the more recent 2019 guideline, which I would say is very pertinent to the discussions that we are having today about performing echocardiography. This is written by Carol Mitchell, another sonographer educator, and she was discussing comprehensive transthoracic echo in adults. It unfortunately doesn't cover the important aspects of transesophageal echo, which are covered in a different guideline, and not really necessary because Dr. Linker did such a great job of that. But I would strongly recommend looking over these guidelines, especially because the second one, the 2019 guideline for performing comprehensive echo, was recently translated into Vietnamese. And I'm sure that Dr. Huai would be able to help you obtain a copy of that if you are interested. So what is new as a sonographer? And I would say what's new as a physician as well, the things that we need to be thinking about in regards to mitral regurgitation. And the reason he's talked about this as being new, because before I think we just took many pictures, 2D pictures, color pictures, and spectral Doppler pictures. But now what we want to do is not only take those pictures, but try to tell a story about the mechanism and the etiology of the mitral regurgitation, because that plays a big role in how it's treated, especially in the era of transcatheter valvular interventions. That means using both 2D and 3D transesophageal echocardiography, transthoracic echo, in order to provide further detail, and of course using transesophageal echo when necessary. We need to follow our algorithms that we know about to assess severity. And again, the other new, but not really new, is the emphasis on quantification whenever that's possible, and it isn't always. We have several tools to assess mitral regurgitation by echo. The pathology itself is really well assessed by transthoracic 2D and 3D, and even better by transesophageal echocardiography. And we should add in this also pathology of the left ventricle and the left atrium, particularly in regards to the size of these structures. And that really constitutes our anatomical assessment. And then there's the use of color Doppler, vena contracta, jet area, less so important, I think, recognized in recent years. And of course, flow convergence, from which we use PISA. This is really the purview and the dynamics of color flow that we need to pay attention to. And then we also need to look at things like mitral E wave, pulsed wave, pulmonary vein pattern, and also calculations using spectral Doppler of our regurgitant flow and regurgitant fraction, regurgitant volume as well, again, using pulsed wave Doppler. And then, of course, continuous wave Doppler, we use that also in calculating regurgitant volume and EROA, but also we want to look at qualitatively the density and the contour of the jet, which can give us clues towards what is going to be the level of severity. And again, as Keith mentions, quantification super important. So here's actually a very practical video that I'm hoping is going to play well. Very important points here about where to place the probe and avoiding foreshortening, which we normally think of as important for the ventricle, but also important for the valves. Here's the next video. Beautiful pictures. Of course, as usual, this is someone with very nice windows, but Keith is an extremely experienced and skillful sonographer. These views that he's getting rival any that I could get by transesophageal echo. So here's his first case of mitral regurgitation here. You can see that this patient has a degree of mitral regurgitation down at this on the lower left-hand side of the screen. But that's not all we want to know. As I mentioned earlier, we want to know what is causing this if we can figure that out. And really, if we look at the ventricle, we can see that it is enlarged and it's poorly contractile. And off the bat, we would think that there is apical tethering due to LV dilatation and global hypokinesis. But if we look more closely at the valve motion itself, we will see things that help us see that as well. We can see that the motion is restricted in systole. It's not actually, it's tethering there. It's not going back any farther. And we might suspect, in fact, that this is due to ischemic MR. And then, of course, I didn't talk about the different types for sake of time, but this would be a 3B. Vena contracta is very helpful. You can see up here on the upper left, if we look at the vena contracta and measure, that's the red arrows in the parasternal long axis view. This can actually be very helpful as a quantitative measure. If you can get the same view every single time, you can compare changes in the size of the vena contracta, but you do have to have the same images each and every time, as we shall see. You can see the different measurements here that Keith is making. And of course, you can do this depending on your orientation with both mild, severe central, and severe eccentric regurgitation. Now, Keith has a few tips for us to remember. You need to angle your transducer to see the complete flow across the valve. You need both the head and the neck of the body in, as it were, the head being this portion up here down on the ventricular side. The neck is where you're actually measuring at the leaflets, and then, of course, the body of the mitral regurgitation jet. You need to examine this over multiple cycles. There can be differences between cardiac cycles, and you need to measure it at the narrowest neck. And one of the reasons that the parasternal long axis view is preferable to look at the Doppler contours is because it's actually near to the screen. Most of the other views that we get, it's pretty far away from the probe, and therefore being able to actually measure that narrow neck contour can get difficult. So then how about the use of 2D and 3D tools to help us in assessing what's going on with mitral regurgitation? Well, as Keith showed you, we want to try to get a 3D full volume of the mitral valve itself, but we also want to do the same thing for the left ventricle. This will give us the best sense of what the size of the left heart is and can give us a reliable stroke volume as well. Plus, we can get a better picture sometimes of regional wall motion as potential causes of mitral regurgitation, although I would say that our usual 2D views can pick up the wall motion usually a bit better unless the patient has wonderful windows, but sometimes the 3D can be helpful for that. But really would recommend that as part of assessing mitral regurgitation, paying special attention to the ventricle is important. And then here are some other views that he was able to get of the mitral valve. You'll note here that he has zoomed in on the mitral valve. It's something called the 3D zoom acquisition. You can visualize both the leaflets from the left ventricle and the leaflets from the left atrial sides and be able to see the motion and sort of get a three-dimensional view of what's going on with the motion of the valve. So you can see it's very nicely displayed here. Again, something that's seen very well by TEE, but in the expert hands, it can also be well seen by transthoracic. And 3D color here, you can get the 3D vena contracta and actually measure it if you have the proper software to do that. And that actually, of course, gives you a better sense of the quantitation of the valve regurgitation itself. Now, you do have to be a bit careful because there can be some bleeding artifact. If you have your gain settings on the walls turned up too high, you can actually obscure the regurgitant jet as well. And sometimes it's difficult to measure it all within the same plane, but certainly worth trying if you have adequate image quality. I think most people who do echo are fairly familiar with. This can give us both the estimated regurgitant orifice area, the regurgitant fraction, and also the regurgitant volume. I'm not going to describe in detail the flow convergence method here, but suffice to say that you're using the color Doppler with the scale adjusted to be able to bring out that hemisphere. You're using the continuous wave Doppler through that jet. And it is, of course, very important to align the continuous wave Doppler with the color jet when at all possible to obtain the very best signal that allows you to make measurements that go into the calculations you see in the box on the left side of the screen. Now, PISA can be tricky at times, especially with eccentric jets. And so you definitely want to try to do your very best to bring out that hemisphere shape. And that does require adjusting some of the settings, gain settings, color settings, everything, in order to be able to get the best pictures. And here are the specific PISA tips that Keith is giving us. Aliasing velocity of 30 to 40, and you definitely want to shift that into the direction of flow. He also recommends zooming in order to get reliable measures. It is easier to measure on a big picture than a small one, but it is difficult. And one should not give up after one attempt, and one should probably not be satisfied after one attempt. It's really going to take looking at it from multiple views, multiple attempts. And again, you want to measure from the leaflets to the aliasing shell. Now, there are limitations to PISA aside from the difficulty in making the measurements. That include all the assumptions about it being actually a hemisphere, and that is the geometry that goes into the equations. And if it's not a hemisphere, then obviously that means the equations will be wrong. The effective regurgitant orifice area may be underestimated in secondary MR, and there's been a lot of controversy about this, but just know that secondary MR that's due to tethering of the ventricle or other problems related to the ventricle, the EROA may not reflect the severity of the valve or the effect of the regurgitation. Less accurate when it's eccentric MR as well. That it has something to do also with the fact that it's not a hemisphere, but also being able to align with the Doppler. And then, of course, if you don't have holosystolic mitral regurgitation, it's not going to be very accurate, or certain measurements are going to be less accurate. Regurgitant volume may be equally as valid, but certainly the EROA will not be. So using other techniques and tools, as we always do, to help us refine the definition of mitral regurgitation. These include semi-quantitative measures, such as the density of the continuous wave jet and the fact that it may be holosystolic. And then, of course, we want to look at the pulmonary veins. There can be systolic blunting, or there can be systolic flow reversal. Here's his first MR case of ischemic MR, and it really helps us to see the difference between mild and severe, with moderate in the middle there, using both our semi-quantitative and quantitative parameters. So in the semi-quantitative parameters for defining mild mitral regurgitation, it would be a small, narrow central jet with normal left atrial and left ventricular sizes. And then the continuous wave jet would not be very dense, it would be soft. And that is in contrast to severe semi-quantitative assessments of mitral regurgitation. One thing is you might just see a flail leaflet, which would signal that this is going to be severe mitral regurgitation a lot of the time. The central jet will be greater than 50% of the left atrial area. That measurement has a lot of caveats with it, but that's oftentimes what we're doing when we actually just look at the size of the jet. An enlarged left ventricle with normal function does not mean that there is normality. The enlargement is the bad thing there. The fact that it's normal function is not necessarily helpful. It's really bad when the function is no longer normal. And of course, pulmonary vein systolic flow reversal, it does not always signal severe regurgitation, and sometimes the pulmonary vein signals are difficult to interpret, but certainly if you see that, you should be thinking that the MR is quite bad. The quantitative measure cutoffs you can see there. Basically, it's sort of the number 3 shows up a lot in mild, whether it's a vena contracted less than 0.3, regurgitant volume less than 30%, 30 milliliters, regurgitant fraction less than 30%. It's kind of an easy way to remember it. The EROA 0.2 is the one outlier. For severity, you have a 7, a 4, a 50, and a 60. And unfortunately, those are a little harder to remember, but that vena contracta should definitely be greater than 2 times the mild cutoff. EROA, same thing. Regurgitant fraction is 50%, and regurgitant volume of 62 times the 30 cutoff for mild. And of course, there you see what we're looking at in terms of mild to moderate ischemic MR. It might be defined in various different ways here. You can see the numbers there. Considerations when we're doing quantification in particular is the degree of aortic regurgitation and severe tricuspid regurgitation, and the fact that all of these can be confounded a lot identify high degrees of ectopy. So we have to be careful. The second case here, you can see it actually is a very anterior jet. And if you look on the left side of the screen, it's very clear that there is prolapse of that posterior mitral valve leaflet and lots of mobility, actually, of both leaflets. The jet is eccentric, and this produces a very difficult time trying to measure the vena contracta. In the second case, then, it's a little bit easier when you go to the apical views and look for Pisa. Now, he took him multiple views and a lot of attempts to align the jet in order to get these very nice pictures. And then he was able to do multiple 3D acquisitions to get a very nice picture of what is going on with the scallops. And you can just sort of see here as I go through it quickly, or slowly rather, you can see that there's a lot of motion again and a lot of prolapse, basically of both of them, but certainly much more of the posterior leaflet. Oh, sorry, it's not advancing for some reason. So, you know, the mitral valve is a challenging valve to look at as much as we like to look at the regurgitation jets that we see all of the time. It is still necessary to go to these other measures depending on the degree of quantitation that we are actually going to need with the mitral regurgitation, and certainly defining characteristics in patients who are asymptomatic. It's vitally important that we define not only the severity of mitral regurgitation, but we actually also very much need to look at ventricular size and function, and probably increasingly left atrial size and function. And I will tell you that it's actually pretty important that we gain a sense of what's going on with the left atrium, because sometimes mitral regurgitation can be related to dilatation of the atrium itself. So let me advance my slides a little bit, and I'll try to screen share again. Hopefully it will work this time. My apologies for the technical difficulties that we seem to be experiencing. So we went through all of that already, and looks like it's not going to want to advance past this slide. So Keith has done a very nice job of putting together this slide set for us. And I hope that everybody has a better sense of how to deal with the mitral valve, and how we can actually do a better job of imaging the mitral valve, and some practical tips and tricks that we can use going forward. Again, thanks to Keith for an excellent job in putting together those slides, and my apologies that my computer would not allow us to see the last two slides. But that is a good time then, I think, to move into our Q&A session. We have Dr. Linker and Dr. Thuy Nguyen available with us here, as of course Dr. Huai, and we're happy to take any questions and comments from the audience about any of the topics that were presented today. Well, let me take the prerogative here actually to go ahead and present our first question. And I'm going to actually do it on mitral regurgitation. I'm very familiar with Dr. Linker and how we do mitral regurgitation imaging at the University of Washington, but I am a little less familiar, to be honest, with how it's done at other centers. And Dr. Thuy Nguyen, I would love to hear the experience of how things are done down south, and the excellent work that you nonetheless do. But any comments on the presentation about mitral regurgitation, any practical emphases that you would be able to bring about imaging mitral regurgitation?
So first, I wanted to say you did a great job presenting that last minute. So that was amazing. It was a great review of everything as well. So because I trained on the West Coast, kind of like you, our imaging is pretty much the same. And I would say in the United States, I think, we all kind of image the mitral valve in a similar way, in the parasternal long axis view, you can kind of get an idea if there's mitral regurgitation. And like you were saying, the mechanism is also very important. I think one key thing is, if you are having issues trying to figure out what the mechanism is, which sometimes we do encounter that on transthoracic echo because, patient body habitus or things like that just, preclude us from getting the best images. Moving on to transesophageal echo, will most of the time really get you the mechanism. And will also help in the quantification of the severity of mitral regurgitation, especially if there's any questions at all. And we obviously will do a transesophageal echo generally on all our patients that we're sending to intervention, whether it be mitral valve ring or mitral clip.
Can I have a question? May I have a question for Jim and Dr. David Linker and Dr. Thuy Nguyen regarding functional MR due to atrial enlargement? Do you have any comment on what we should pay attention to when we do MR quantification for this kind of MR?
You want to take
David,
that?
do you want to take that one?
Well, so just a first comment in looking at the mitral valve. The same comment that I had about the RVOT and pulmonic valve is true for the mitral valve. There's tremendous variability of the orientation of the mitral valve, so that often when we do sort of our fixed angles, it can be very confusing as to what we're looking at. And so it just helps to have our mental model, to discard our mental model and realize that we should just be looking at whatever the patient's anatomy is telling us. And I think that you highlight one of the very important sources of mitral regurgitation. And rather than focusing on one kind, I think that when we're planning to send somebody for a mitral intervention, I envision myself trying to give the interventionist or the surgeon a roadmap, that an understanding of what is the anatomy that's causing this problem, what is the physiology that's going on. And the annular dilation is one of the types of anatomy that can be causing the problem. Personally, I don't think it makes a big difference in terms of quantification, with the one exception that if you are a proponent of PISA and you have multiple jets, you're out of luck. but I'm not a big fan of PISA anyway. I try to look at a physiologic approach, saying what is the impact on this patient's physiology, and looking at the all four pulmonary veins and taking a holistic view. So that isn't an exact answer to your question, but I hope it helps.
Yeah, thank you very much. So we should pay attention to annular size,
yes,
better than quantification of MR in atrial enlargement patient.
Yeah. Well, I think that quantification is important.
Yes.
But I think that we have to. There's one of the things I tell our fellows, that for every complex problem, there's a simple answer that's wrong. And so we should always try to take a holistic view of what's going on, try to understand everything that's going on, the anatomy and the physiology, how this is impacting the patient's physiology. Quantification is only part of the puzzle.
Yeah, thank you, David.
Yeah.
I think that's really well said. We have in echo the opportunity, and in other cardiac imaging as well, to integrate so many different findings instead of using just one measurement or even just several measurements, but to sort of put this all together and help clinicians, help ourselves to understand what's going on. And that will help us actually arrive at the right therapies and treatments. I just think about diastolic dysfunction and the fact that, we tried all of these different therapies and none of them worked very well. And we began to get very, very thinking that there would never be any specific therapy for diastolic function. And I think now it's very well recognized. It's because we tried to give therapies for many different causes of diastolic dysfunction.
Mhm.
We tried to look at it as an overly simplistic way, and our simple answer was wrong for some of them. It was probably right for some of them, but wrong for others.
That's a small
And
subset.
the more nuanced we get, the better. Yeah,
Yeah.
very small subset. So using imaging then to define better what's going on will help us towards better therapies.
Mhm.
And thank you, Jim. And I have one more question for David. Can you advise is there any change in practice when we do TEE for in COVID time? The indication and how to prepare.
So that's actually not an echo question. So I'll try to answer, but then I may pass it off to Dr. Kirkpatrick. I think that in COVID, then we have a very challenging ethical consideration. We have to balance the care of the individual patient and the care of the health of the healthcare workers and the resources of our hospital and our healthcare system. And so I think that we have to, it's basically similar to whenever we're doing a TEE, we should always be looking at risk versus benefits, but we just have to realize that we maybe have to raise the threshold for doing a TEE quite a bit, and that it should be really important for the patient's care.
Yeah, thank you, David.
I would very much agree with that. There are several things that have been proposed for reducing transmission risk. One of them is to actually cover the TEE with a plastic sheet and to try to prevent it from being used as a fomite, essentially, by the virus. But I think really the most important thing is exactly what Dr. Linker said, and that is the right test needs to be done on the right patient, considering all of those factors. There are two ways to look at that. One, from a lab operations standpoint, one would be to say, well, we're going to cancel all of the tests, and then we're only going to do the tests that really, really, really have to be done. And so that would be a very restrictive way of thinking about it. Mm-hmm. The other way would be to say, we're not going to cancel all the tests, but we're basically going to defer or not do the ones that don't need to be done. And that may sound like it's the same thing, but it's actually a different way of looking at it. And I would argue for the second, because what we have seen in the United States, and perhaps you've seen this too, is that when we cancel everything, people end up not getting the care, particularly the diagnostic care that they need. They present late, they have more complications, and there's a lot of problems that come up with that. And actually, that may end up in a worse transmission situation, because then the patient's coming in with acute coronary syndrome or something else, and they're filling all of the hospitals, and they're farther along than they would have been if we'd found the problem earlier. And there are a lot of problems when that happens. So I think we're still trying to figure all of this out, but thinking about it from the patient perspective as well as the larger transmission perspective, I do think is important.
Thank you, Jim. And I have a question for Dr. Thuy Nguyen about the role of RV strain in assessing the hemodynamic compromised patient.
Yeah, so, I think the LV strain is, we're starting to implement it. Initially, the initial issues with using strain was everyone said, each vendor kind of had different values. And if you were going to use it, you should make sure you use the same machine, scan the same way. But I think those kind of issues have now kind of been put away a little bit, because I now think all the vendors are kind of the same, whereas an LV strain that is, greater than 17 is considered normal. Anything less than that is kind of abnormal. I think RV strain is usable, but I just don't feel that it's gotten as much attention as LV strain. And I think the values for normal I think we're kind of adapting from the LV, but I think it's still kind of, questionable. I think assessing RV function is actually quite tricky. We have RV ejection fraction, but then, we try to come up with other parameters like RV stroke work index, which is, more looking at the contractility without, taking into consideration the preload and the afterload. So it's kind of just looking at the intrinsic contractility of the RV. And that's something that, a lot of the critical care teams, the ICU teams, cardiac transplant, especially LVADs, use. So I think, RV strain has a role, but I just don't know in terms of kind of how far we've come along on that side. I don't know if Dr. Linker or Dr. Kirkpatrick has anything else to add to that.
I don't think so. I think you said it very well.
Said. I agree.
RV is a tricky structure. Yeah.
I think we have a lot to learn about RV function, and we're just in our infancy of learning it.
I agree.
Yeah, thank you.
That's one topic I think would be good for a future training village, to be honest. We actually recently did a quality assurance assessment in which we had several attendings look at the same images of the right ventricle and then say whether they thought it was mild, moderate, severe, or normally. And I can tell you for some of them, I was very dismayed because people read it very differently just by the eyeball technique. Worse than LV ejection fraction, I think. So I think that says several things. One of which it says is we have to be paying attention to artifacts and scanning in the proper way. And the way the ASE has said in the chamber quantification guidelines is that looking at the RV really should be done for function and size in 2D from the RV focused view. It basically is looking from the LV apex down across the LV at the RV. The RV should be oriented on the left side of the screen, and the point of the RV should be pointing straight up. The apex should not be over where the transducer is. But as Dr. Linker pointed out in our QA session, even when that happens, there can be significant artifact that actually shadows out the right ventricular free wall systolic function. In one of the cases, it created the appearance that it was completely normal, but actually, if you looked more carefully or looked at another attempt at a view, it was clearly abnormal. So that said, yes, and I really appreciate you bringing that up because that was the source of variability. So what I would say is I think despite the fact that strain the RV is early on, maybe in its adolescence at this point, RV3D also needs to be better developed. We need these extra techniques because as Dr. Tweewind said, it is so hard to image the RV. We need these other techniques. We need to get good at them. And I would encourage everybody to begin to practice RV strain and RV3D so that we can be ready once things are a little bit more developed.
To actually date myself and also explain how difficult the RV is. Literally 40 years ago, when I started my research as a cardiology fellow, my research was on RV 3D volumes. And it was by echo. And it was highly successful. And I had to make a decision whether I was going to continue working on that as a research project. And I chose not to because I thought, I don't understand the RV function well enough or how to use this physiologically or clinically. And I think 40 years later, I'm kind of glad I didn't spend a lot of time on that.
Although, David, perhaps if you had, then we'd be further along. So
well,
there's two ways to look at that.
I thought I wasn't smart enough to figure it out. So
well, I beg to differ. You certainly feel. Well, we're coming to the end of our session. I just want to give a quick wrap up and overview of everything. We had tremendous talks today, I thought, on a number of wonderful, wonderful topics by wonderful, wonderful speakers. We appreciate so much Dr. Tweewind telling us about the Echo Swan and the ways that we can measure hemodynamics by echocardiography, even if they don't completely replace or maybe even challenge invasive techniques, still things like RV Stroke Work Index are very important. And there's all techniques that we should learn and get better in over time. We appreciated Todd Zwink giving an excellent talk about the pericardium, as he always does. Very practical tips and tricks for assessing pericardial effusions and their hemodynamic significance, and also guiding pericardiocentesis, and also in that great case, looking for perforations using contrast. We also really appreciated Dr. Akhter's talk. It was truly excellent on cardiotoxicity and how we measure that, particularly by strain. And I was struck by her discussions of the extra uses of strain, looking at the polar maps and being able to figure out what's going on with the patient, and also the new data that's coming out about how strain might be used, not necessarily to replace ejection fraction, but to identify patients who are actually at greater risk and are going to go on and maybe even need some intervening, not necessarily stopping their chemo, but other interventions such as starting therapy for cardiomyopathy. So stay tuned, and many other things will come down the pike with that. And I want to really acknowledge Dr. David Linker in particular for his phenomenal tips and tricks regarding transesophageal echocardiography. David, I know you just scratched the surface of what you cover in your book. There are many other things that are in there. I would love to have you come back and talk more about the other aspects, because tremendous job. And
I could write a book about it. Actually, I just did.
You did. And many thanks also to Keith Collins for a wonderful job in putting together some slides on mitral regurgitation. Wish I had done a better job presenting them, but certainly an important topic that we all need to continue to pay attention to. And of course, I would be remiss not to thank very much Dr. Huai Nguyen and the great job that she did in organizing this section. Wonderful collaborator over the years. She's just been a phenomenal colleague to work with. And thank you so much, Dr. Nguyen and Dr. Thuy Nguyen and Dr. Linker and Mr. Todd Zwink and Mr. Keith Collins for what I think has been an excellent session. And Huai, take it away for the last few comments.
Oh, thank you so much, Jim, David, and Thuy Nguyen. This was a wonderful section, brilliant, and I have heard from the organizing committee that our section was the hottest section this morning at the conference, and I really appreciate your precious support and your effort to bring so many knowledge and skills to Vietnamese cardiology and echocardiologists and echocardiographer. And I hope that we will meet together in the near future when the pandemic comes to an end. We will meet in person and we'll have a conference in person. Thank you so much, and we look forward to more interacting sessions like this. Thank you so much, Jim, for your great effort to put everyone together. Thank you so much, David, for many years contribution to the education for Vietnamese cardiologists. Thank you, Dr. Thuy Nguyen. Yes, thank you so much.
It's a pleasure.
Thank you for having us.
Take care, everyone.
Take care. Yeah.
Tim mạch học là một chuyên ngành y học hết sức sôi động và thường xuyên được cập nhật. Đại dịch Covid đã và đang thay đổi sâu sắc thế giới. Mọi khía cạnh của đời sống xã hội bị ảnh hưởng nghiêm trọng và đặt ra những vấn đề thách thức chưa từng có đối với các thầy thuốc nói chung và các bác sĩ chuyên khoa tim mạch nói riêng.
Vinh dự và tự hào khoác trên mình chiếc áo blue trắng, mỗi người thầy thuốc chúng ta luôn tự nhủ, ngoài sự cảm thông, yêu thương người bệnh, chúng ta luôn cần phải trau dồi và cập nhật các cái kiến thức chuyên môn của mình. Học tập là một quá trình liên tục và xuyên suốt trong cả sự nghiệp hành nghề của chúng ta. Học từ các thầy cô, từ anh chị em đồng nghiệp và từ chính người bệnh của chúng ta. Vì thế, các hội nghị, hội thảo khoa học, các khóa đào tạo liên tục luôn là những cơ hội để học tập và trao đổi kỹ năng nghề nghiệp của các thầy thuốc tim mạch chúng ta.
Ngành tim mạch Việt Nam trong những năm vừa qua đã có những bước phát triển vượt bậc. Các trung tâm tim mạch trên khắp cả nước đã có sự phát triển về cả chiều sâu và bề rộng. Hội Tim mạch Việt Nam cùng các phân hội là những tổ chức nghề nghiệp đã quy tụ được đông đảo các bác sĩ chuyên ngành tim mạch cũng như cộng đồng y khoa thông qua việc tổ chức các hội nghị, hội thảo và các khóa đào tạo liên tục. Hội nghị khoa học tim mạch toàn quốc năm nay là một minh chứng với sự tham gia của trên 300 các báo cáo viên, diễn giả nổi tiếng trên thế giới và trong nước, được phát cùng lúc trên 10 kênh trực tuyến và hàng loạt các chương trình đào tạo liên tục.
Chúng ta đã trải qua nhiều mất mát và thử thách. Nhưng hơn bao giờ hết, các bác sĩ chuyên khoa tim mạch sẽ nỗ lực đoàn kết hơn. Sự nghiệp bảo vệ tim mạch sẽ không bao giờ nghỉ ngơi, không giới hạn và không khoảng cách giữa mỗi chúng ta. Chào mừng quý vị đến với Hội nghị Tim mạch Toàn quốc Việt Nam 2021. Tim mạch học là một chuyên ngành y học hết sức sôi động và thường xuyên được cập nhật. Đại dịch Covid đã và đang thay đổi sâu sắc thế giới. Mọi khía cạnh của đời sống xã hội bị ảnh hưởng nghiêm trọng và đặt ra những vấn đề thách thức chưa từng có đối với các thầy thuốc nói chung và các bác sĩ chuyên khoa tim mạch nói riêng.
Vinh dự và tự hào khoác trên mình chiếc áo blue trắng, mỗi người thầy thuốc chúng ta luôn tự nhủ, ngoài sự cảm thông, yêu thương người bệnh, chúng ta luôn cần phải trau dồi và cập nhật các cái kiến thức chuyên môn của mình. Học tập là một quá trình liên tục và xuyên suốt trong cả sự nghiệp hành nghề của chúng ta. Học từ các thầy cô, từ anh chị em đồng nghiệp và từ chính người bệnh của chúng ta. Vì thế, các hội nghị, hội thảo khoa học, các khóa đào tạo liên tục luôn là những cơ hội để học tập và trao đổi kỹ năng nghề nghiệp của các thầy thuốc tim mạch chúng ta.
Ngành tim mạch Việt Nam trong những năm vừa qua đã có những bước phát triển vượt bậc. Các trung tâm tim mạch trên khắp cả nước đã có sự phát triển về cả chiều sâu và bề rộng. Hội Tim mạch Việt Nam cùng các phân hội là những tổ chức nghề nghiệp đã quy tụ được đông đảo các bác sĩ chuyên ngành tim mạch cũng như cộng đồng y khoa thông qua việc tổ chức các hội nghị, hội thảo và các khóa đào tạo liên tục. Hội nghị khoa học tim mạch toàn quốc năm nay là một minh chứng với sự tham gia của trên 300 các báo cáo viên, diễn giả nổi tiếng trên thế giới và trong nước, được phát cùng lúc trên 10 kênh trực tuyến và hàng loạt các chương trình đào tạo liên tục.
Chúng ta đã trải qua nhiều mất mát và thử thách. Nhưng hơn bao giờ hết, các bác sĩ chuyên khoa tim mạch sẽ nỗ lực đoàn kết hơn. Sự nghiệp bảo vệ tim mạch sẽ không bao giờ nghỉ ngơi, không giới hạn và không khoảng cách giữa mỗi chúng ta. Chào mừng quý vị đến với Hội nghị Tim mạch Toàn quốc Việt Nam 2021. Tim mạch học là một chuyên ngành y học hết sức sôi động và thường xuyên được cập nhật. Đại dịch Covid đã và đang thay đổi sâu sắc thế giới. Mọi khía cạnh của đời sống xã hội bị ảnh hưởng nghiêm trọng và đặt ra những vấn đề thách thức chưa từng có đối với các thầy thuốc nói chung và các bác sĩ chuyên khoa tim mạch nói riêng.
Vinh dự và tự hào khoác trên mình chiếc áo blue trắng, mỗi người thầy thuốc chúng ta luôn tự nhủ, ngoài sự cảm thông, yêu thương người bệnh, chúng ta luôn cần phải trau dồi và cập nhật các cái kiến thức chuyên môn của mình. Học tập là một quá trình liên tục và xuyên suốt trong cả sự nghiệp hành nghề của chúng ta. Học từ các thầy cô, từ anh chị em đồng nghiệp và từ chính người bệnh của chúng ta. Vì thế, các hội nghị, hội thảo khoa học, các khóa đào tạo liên tục luôn là những cơ hội để học tập và trao đổi kỹ năng nghề nghiệp của các thầy thuốc tim mạch chúng ta.
Ngành tim mạch Việt Nam trong những năm vừa qua đã có những bước phát triển vượt bậc. Các trung tâm tim mạch trên khắp cả nước đã có sự phát triển về cả chiều sâu và bề rộng. Hội Tim mạch Việt Nam cùng các phân hội là những tổ chức nghề nghiệp đã quy tụ được đông đảo các bác sĩ chuyên ngành tim mạch cũng như cộng đồng y khoa thông qua việc tổ chức các hội nghị, hội thảo và các khóa đào tạo liên tục. Hội nghị khoa học tim mạch toàn quốc năm nay là một minh chứng với sự tham gia của trên 300 các báo cáo viên, diễn giả nổi tiếng trên thế giới và trong nước, được phát cùng lúc trên 10 kênh trực tuyến và hàng loạt các chương trình đào tạo liên tục.
Chúng ta đã trải qua nhiều mất mát và thử thách. Nhưng hơn bao giờ hết, các bác sĩ chuyên khoa tim mạch sẽ nỗ lực đoàn kết hơn. Sự nghiệp bảo vệ tim mạch sẽ không bao giờ nghỉ ngơi, không giới hạn và không khoảng cách giữa mỗi chúng ta. Chào mừng quý vị đến với Hội nghị Tim mạch Toàn quốc Việt Nam 2021. Tim mạch học là một chuyên ngành y học hết sức sôi động và thường xuyên được cập nhật. Đại dịch Covid đã và đang thay đổi sâu sắc thế giới. Mọi khía cạnh của đời sống xã hội bị ảnh hưởng nghiêm trọng và đặt ra những vấn đề thách thức chưa từng có đối với các thầy thuốc nói chung và các bác sĩ chuyên khoa tim mạch nói riêng.
Vinh dự và tự hào khoác trên mình chiếc áo blue trắng, mỗi người thầy thuốc chúng ta luôn tự nhủ, ngoài sự cảm thông, yêu thương người bệnh, chúng ta luôn cần phải trau dồi và cập nhật các cái kiến thức chuyên môn của mình. Học tập là một quá trình liên tục và xuyên suốt trong cả sự nghiệp hành nghề của chúng ta. Học từ các thầy cô, từ anh chị em đồng nghiệp và từ chính người bệnh của chúng ta. Vì thế, các hội nghị, hội thảo khoa học, các khóa đào tạo liên tục luôn là những cơ hội để học tập và trao đổi kỹ năng nghề nghiệp của các thầy thuốc tim mạch chúng ta.
Ngành tim mạch Việt Nam trong những năm vừa qua đã có những bước phát triển vượt bậc. Các trung tâm tim mạch trên khắp cả nước đã có sự phát triển về cả chiều sâu và bề rộng. Hội Tim mạch Việt Nam cùng các phân hội là những tổ chức nghề nghiệp đã quy tụ được đông đảo các bác sĩ chuyên ngành tim mạch cũng như cộng đồng y khoa thông qua việc tổ chức các hội nghị, hội thảo và các khóa đào tạo liên tục. Hội nghị khoa học tim mạch toàn quốc năm nay là một minh chứng với sự tham gia của trên 300 các báo cáo viên, diễn giả nổi tiếng trên thế giới và trong nước, được phát cùng lúc trên 10 kênh trực tuyến và hàng loạt các chương trình đào tạo liên tục.
Chúng ta đã trải qua nhiều mất mát và thử thách. Nhưng hơn bao giờ hết, các bác sĩ chuyên khoa tim mạch sẽ nỗ lực đoàn kết hơn. Sự nghiệp bảo vệ tim mạch sẽ không bao giờ nghỉ ngơi, không giới hạn và không khoảng cách giữa mỗi chúng ta. Chào mừng quý vị đến với Hội nghị Tim mạch Toàn quốc Việt Nam 2021. Tim mạch học là một chuyên ngành y học hết sức sôi động và thường xuyên được cập nhật. Đại dịch Covid đã và đang thay đổi sâu sắc thế giới. Mọi khía cạnh của đời sống xã hội bị ảnh hưởng nghiêm trọng và đặt ra những vấn đề thách thức chưa từng có đối với các thầy thuốc nói chung và các bác sĩ chuyên khoa tim mạch nói riêng.
Vinh dự và tự hào khoác trên mình chiếc áo blue trắng, mỗi người thầy thuốc chúng ta luôn tự nhủ, ngoài sự cảm thông, yêu thương người bệnh, chúng ta luôn cần phải trau dồi và cập nhật các cái kiến thức chuyên môn của mình. Học tập là một quá trình liên tục và xuyên suốt trong cả sự nghiệp hành nghề của chúng ta. Học từ các thầy cô, từ anh chị em đồng nghiệp và từ chính người bệnh của chúng ta. Vì thế, các hội nghị, hội thảo khoa học, các khóa đào tạo liên tục luôn là những cơ hội để học tập và trao đổi kỹ năng nghề nghiệp của các thầy thuốc tim mạch chúng ta.
Ngành tim mạch Việt Nam trong những năm vừa qua đã có những bước phát triển vượt bậc. Các trung tâm tim mạch trên khắp cả nước đã có sự phát triển về cả chiều sâu và bề rộng. Hội Tim mạch Việt Nam cùng các phân hội là những tổ chức nghề nghiệp đã quy tụ được đông đảo các bác sĩ chuyên ngành tim mạch cũng như cộng đồng y khoa thông qua việc tổ chức các hội nghị, hội thảo và các khóa đào tạo liên tục. Hội nghị khoa học tim mạch toàn quốc năm nay là một minh chứng với sự tham gia của trên 300 các báo cáo viên, diễn giả nổi tiếng trên thế giới và trong nước, được phát cùng lúc trên 10 kênh trực tuyến và hàng loạt các chương trình đào tạo liên tục.
Chúng ta đã trải qua nhiều mất mát và thử thách. Nhưng hơn bao giờ hết, các bác sĩ chuyên khoa tim mạch sẽ nỗ lực đoàn kết hơn. Sự nghiệp bảo vệ tim mạch sẽ không bao giờ nghỉ ngơi, không giới hạn và không khoảng cách giữa mỗi chúng ta. Chào mừng quý vị đến với Hội nghị Tim mạch Toàn quốc Việt Nam 2021. Tim mạch học là một chuyên ngành y học hết sức sôi động và thường xuyên được cập nhật. Đại dịch Covid đã và đang thay đổi sâu sắc thế giới. Mọi khía cạnh của đời sống xã hội bị ảnh hưởng nghiêm trọng và đặt ra những vấn đề thách thức chưa từng có đối với các thầy thuốc nói chung và các bác sĩ chuyên khoa tim mạch nói riêng.
Vinh dự và tự hào khoác trên mình chiếc áo blue trắng, mỗi người thầy thuốc chúng ta luôn tự nhủ, ngoài sự cảm thông, yêu thương người bệnh, chúng ta luôn cần phải trau dồi và cập nhật các cái kiến thức chuyên môn của mình. Học tập là một quá trình liên tục và xuyên suốt trong cả sự nghiệp hành nghề của chúng ta. Học từ các thầy cô, từ anh chị em đồng nghiệp và từ chính người bệnh của chúng ta. Vì thế, các hội nghị, hội thảo khoa học, các khóa đào tạo liên tục luôn là những cơ hội để học tập và trao đổi kỹ năng nghề nghiệp của các thầy thuốc tim mạch chúng ta.
Ngành tim mạch Việt Nam trong những năm vừa qua đã có những bước phát triển vượt bậc. Các trung tâm tim mạch trên khắp cả nước đã có sự phát triển về cả chiều sâu và bề rộng. Hội Tim mạch Việt Nam cùng các phân hội là những tổ chức nghề nghiệp đã quy tụ được đông đảo các bác sĩ chuyên ngành tim mạch cũng như cộng đồng y khoa thông qua việc tổ chức các hội nghị, hội thảo và các khóa đào tạo liên tục. Hội nghị khoa học tim mạch toàn quốc năm nay là một minh chứng với sự tham gia của trên 300 các báo cáo viên, diễn giả nổi tiếng trên thế giới và trong nước, được phát cùng lúc trên 10 kênh trực tuyến và hàng loạt các chương trình đào tạo liên tục.
Chúng ta đã trải qua nhiều mất mát và thử thách. Nhưng hơn bao giờ hết, các bác sĩ chuyên khoa tim mạch sẽ nỗ lực đoàn kết hơn. Sự nghiệp bảo vệ tim mạch sẽ không bao giờ nghỉ ngơi, không giới hạn và không khoảng cách giữa mỗi chúng ta. Chào mừng quý vị đến với Hội nghị Tim mạch Toàn quốc Việt Nam 2021. Tim mạch học là một chuyên ngành y học hết sức sôi động và thường xuyên được cập nhật. Đại dịch Covid đã và đang thay đổi sâu sắc thế giới. Mọi khía cạnh của đời sống xã hội bị ảnh hưởng nghiêm trọng và đặt ra những vấn đề thách thức chưa từng có đối với các thầy thuốc nói chung và các bác sĩ chuyên khoa tim mạch nói riêng.
Vinh dự và tự hào khoác trên mình chiếc áo blue trắng, mỗi người thầy thuốc chúng ta luôn tự nhủ, ngoài sự cảm thông, yêu thương người bệnh, chúng ta luôn cần phải trau dồi và cập nhật các cái kiến thức chuyên môn của mình. Học tập là một quá trình liên tục và xuyên suốt trong cả sự nghiệp hành nghề của chúng ta. Học từ các thầy cô, từ anh chị em đồng nghiệp và từ chính người bệnh của chúng ta. Vì thế, các hội nghị, hội thảo khoa học, các khóa đào tạo liên tục luôn là những cơ hội để học tập và trao đổi kỹ năng nghề nghiệp của các thầy thuốc tim mạch chúng ta.
Ngành tim mạch Việt Nam trong những năm vừa qua đã có những bước phát triển vượt bậc. Các trung tâm tim mạch trên khắp cả nước đã có sự phát triển về cả chiều sâu và bề rộng. Hội Tim mạch Việt Nam cùng các phân hội là những tổ chức nghề nghiệp đã quy tụ được đông đảo các bác sĩ chuyên ngành tim mạch cũng như cộng đồng y khoa thông qua việc tổ chức các hội nghị, hội thảo và các khóa đào tạo liên tục. Hội nghị khoa học tim mạch toàn quốc năm nay là một minh chứng với sự tham gia của trên 300 các báo cáo viên, diễn giả nổi tiếng trên thế giới và trong nước, được phát cùng lúc trên 10 kênh trực tuyến và hàng loạt các chương trình đào tạo liên tục.
Chúng ta đã trải qua nhiều mất mát và thử thách. Nhưng hơn bao giờ hết, các bác sĩ chuyên khoa tim mạch sẽ nỗ lực đoàn kết hơn. Sự nghiệp bảo vệ tim mạch sẽ không bao giờ nghỉ ngơi, không giới hạn và không khoảng cách giữa mỗi chúng ta. Chào mừng quý vị đến với Hội nghị Tim mạch Toàn quốc Việt Nam 2021. Tim mạch học là một chuyên ngành y học hết sức sôi động và thường xuyên được cập nhật. Đại dịch Covid đã và đang thay đổi sâu sắc thế giới. Mọi khía cạnh của đời sống xã hội bị ảnh hưởng nghiêm trọng và đặt ra những vấn đề thách thức chưa từng có đối với các thầy thuốc nói chung và các bác sĩ chuyên khoa tim mạch nói riêng.
Vinh dự và tự hào khoác trên mình chiếc áo blue trắng, mỗi người thầy thuốc chúng ta luôn tự nhủ, ngoài sự cảm thông, yêu thương người bệnh, chúng ta luôn cần phải trau dồi và cập nhật các cái kiến thức chuyên môn của mình. Học tập là một quá trình liên tục và xuyên suốt trong cả sự nghiệp hành nghề của chúng ta. Học từ các thầy cô, từ anh chị em đồng nghiệp và từ chính người bệnh của chúng ta. Vì thế, các hội nghị, hội thảo khoa học, các khóa đào tạo liên tục luôn là những cơ hội để học tập và trao đổi kỹ năng nghề nghiệp của các thầy thuốc tim mạch chúng ta.
Ngành tim mạch Việt Nam trong những năm vừa qua đã có những bước phát triển vượt bậc. Các trung tâm tim mạch trên khắp cả nước đã có sự phát triển về cả chiều sâu và bề rộng. Hội Tim mạch Việt Nam cùng các phân hội là những tổ chức nghề nghiệp đã quy tụ được đông đảo các bác sĩ chuyên ngành tim mạch cũng như cộng đồng y khoa thông qua việc tổ chức các hội nghị, hội thảo và các khóa đào tạo liên tục. Hội nghị khoa học tim mạch toàn quốc năm nay là một minh chứng với sự tham gia của trên 300 các báo cáo viên, diễn giả nổi tiếng trên thế giới và trong nước, được phát cùng lúc trên 10 kênh trực tuyến và hàng loạt các chương trình đào tạo liên tục.
Chúng ta đã trải qua nhiều mất mát và thử thách. Nhưng hơn bao giờ hết, các bác sĩ chuyên khoa tim mạch sẽ nỗ lực đoàn kết hơn. Sự nghiệp bảo vệ tim mạch sẽ không bao giờ nghỉ ngơi, không giới hạn và không khoảng cách giữa mỗi chúng ta. Chào mừng quý vị đến với Hội nghị Tim mạch Toàn quốc Việt Nam 2021. Tim mạch học là một chuyên ngành y học hết sức sôi động và thường xuyên được cập nhật. Đại dịch Covid đã và đang thay đổi sâu sắc thế giới. Mọi khía cạnh của đời sống xã hội bị ảnh hưởng nghiêm trọng và đặt ra những vấn đề thách thức chưa từng có đối với các thầy thuốc nói chung và các bác sĩ chuyên khoa tim mạch nói riêng.
Vinh dự và tự hào khoác trên mình chiếc áo blue trắng, mỗi người thầy thuốc chúng ta luôn tự nhủ, ngoài sự cảm thông, yêu thương người bệnh, chúng ta luôn cần phải trau dồi và cập nhật các cái kiến thức chuyên môn của mình. Học tập là một quá trình liên tục và xuyên suốt trong cả sự nghiệp hành nghề của chúng ta. Học từ các thầy cô, từ anh chị em đồng nghiệp và từ chính người bệnh của chúng ta. Vì thế, các hội nghị, hội thảo khoa học, các khóa đào tạo liên tục luôn là những cơ hội để học tập và trao đổi kỹ năng nghề nghiệp của các thầy thuốc tim mạch chúng ta.
Ngành tim mạch Việt Nam trong những năm vừa qua đã có những bước phát triển vượt bậc. Các trung tâm tim mạch trên khắp cả nước đã có sự phát triển về cả chiều sâu và bề rộng. Hội Tim mạch Việt Nam cùng các phân hội là những tổ chức nghề nghiệp đã quy tụ được đông đảo các bác sĩ chuyên ngành tim mạch cũng như cộng đồng y khoa thông qua việc tổ chức các hội nghị, hội thảo và các khóa đào tạo liên tục. Hội nghị khoa học tim mạch toàn quốc năm nay là một minh chứng với sự tham gia của trên 300 các báo cáo viên, diễn giả nổi tiếng trên thế giới và trong nước, được phát cùng lúc trên 10 kênh trực tuyến và hàng loạt các chương trình đào tạo liên tục.
Chúng ta đã trải qua nhiều mất mát và thử thách. Nhưng hơn bao giờ hết, các bác sĩ chuyên khoa tim mạch sẽ nỗ lực đoàn kết hơn. Sự nghiệp bảo vệ tim mạch sẽ không bao giờ nghỉ ngơi, không giới hạn và không khoảng cách giữa mỗi chúng ta. Chào mừng quý vị đến với Hội nghị Tim mạch Toàn quốc Việt Nam 2021. Tim mạch học là một chuyên ngành y học hết sức sôi động và thường xuyên được cập nhật. Đại dịch Covid đã và đang thay đổi sâu sắc thế giới. Mọi khía cạnh của đời sống xã hội bị ảnh hưởng nghiêm trọng và đặt ra những vấn đề thách thức chưa từng có đối với các thầy thuốc nói chung và các bác sĩ chuyên khoa tim mạch nói riêng.
Vinh dự và tự hào khoác trên mình chiếc áo blue trắng, mỗi người thầy thuốc chúng ta luôn tự nhủ, ngoài sự cảm thông, yêu thương người bệnh, chúng ta luôn cần phải trau dồi và cập nhật các cái kiến thức chuyên môn của mình. Học tập là một quá trình liên tục và xuyên suốt trong cả sự nghiệp hành nghề của chúng ta. Học từ các thầy cô, từ anh chị em đồng nghiệp và từ chính người bệnh của chúng ta. Vì thế, các hội nghị, hội thảo khoa học, các khóa đào tạo liên tục luôn là những cơ hội để học tập và trao đổi kỹ năng nghề nghiệp của các thầy thuốc tim mạch chúng ta.
Ngành tim mạch Việt Nam trong những năm vừa qua đã có những bước phát triển vượt bậc. Các trung tâm tim mạch trên khắp cả nước đã có sự phát triển về cả chiều sâu và bề rộng. Hội Tim mạch Việt Nam cùng các phân hội là những tổ chức nghề nghiệp đã quy tụ được đông đảo các bác sĩ chuyên ngành tim mạch cũng như cộng đồng y khoa thông qua việc tổ chức các hội nghị, hội thảo và các khóa đào tạo liên tục. Hội nghị khoa học tim mạch toàn quốc năm nay là một minh chứng với sự tham gia của trên 300 các báo cáo viên, diễn giả nổi tiếng trên thế giới và trong nước, được phát cùng lúc trên 10 kênh trực tuyến và hàng loạt các chương trình đào tạo liên tục.
Chúng ta đã trải qua nhiều mất mát và thử thách. Nhưng hơn bao giờ hết, các bác sĩ chuyên khoa tim mạch sẽ nỗ lực đoàn kết hơn. Sự nghiệp bảo vệ tim mạch sẽ không bao giờ nghỉ ngơi, không giới hạn và không khoảng cách giữa mỗi chúng ta. Chào mừng quý vị đến với Hội nghị Tim mạch Toàn quốc Việt Nam 2021. Tim mạch học là một chuyên ngành y học hết sức sôi động và thường xuyên được cập nhật. Đại dịch Covid đã và đang thay đổi sâu sắc thế giới. Mọi khía cạnh của đời sống xã hội bị ảnh hưởng nghiêm trọng và đặt ra những vấn đề thách thức chưa từng có đối với các thầy thuốc nói chung và các bác sĩ chuyên khoa tim mạch nói riêng.
Vinh dự và tự hào khoác trên mình chiếc áo blue trắng, mỗi người thầy thuốc chúng ta luôn tự nhủ, ngoài sự cảm thông, yêu thương người bệnh, chúng ta luôn cần phải trau dồi và cập nhật các cái kiến thức chuyên môn của mình. Học tập là một quá trình liên tục và xuyên suốt trong cả sự nghiệp hành nghề của chúng ta. Học từ các thầy cô, từ anh chị em đồng nghiệp và từ chính người bệnh của chúng ta. Vì thế, các hội nghị, hội thảo khoa học, các khóa đào tạo liên tục luôn là những cơ hội để học tập và trao đổi kỹ năng nghề nghiệp của các thầy thuốc tim mạch chúng ta.
Ngành tim mạch Việt Nam trong những năm vừa qua đã có những bước phát triển vượt bậc. Các trung tâm tim mạch trên khắp cả nước đã có sự phát triển về cả chiều sâu và bề rộng. Hội Tim mạch Việt Nam cùng các phân hội là những tổ chức nghề nghiệp đã quy tụ được đông đảo các bác sĩ chuyên ngành tim mạch cũng như cộng đồng y khoa thông qua việc tổ chức các hội nghị, hội thảo và các khóa đào tạo liên tục. Hội nghị khoa học tim mạch toàn quốc năm nay là một minh chứng với sự tham gia của trên 300 các báo cáo viên, diễn giả nổi tiếng trên thế giới và trong nước, được phát cùng lúc trên 10 kênh trực tuyến và hàng loạt các chương trình đào tạo liên tục.
Chúng ta đã trải qua nhiều mất mát và thử thách. Nhưng hơn bao giờ hết, các bác sĩ chuyên khoa tim mạch sẽ nỗ lực đoàn kết hơn. Sự nghiệp bảo vệ tim mạch sẽ không bao giờ nghỉ ngơi, không giới hạn và không khoảng cách giữa mỗi chúng ta. Chào mừng quý vị đến với Hội nghị Tim mạch Toàn quốc Việt Nam 2021. Tim mạch học là một chuyên ngành y học hết sức sôi động và thường xuyên được cập nhật. Đại dịch Covid đã và đang thay đổi sâu sắc thế giới. Mọi khía cạnh của đời sống xã hội bị ảnh hưởng nghiêm trọng và đặt ra những vấn đề thách thức chưa từng có đối với các thầy thuốc nói chung và các bác sĩ chuyên khoa tim mạch nói riêng.
Vinh dự và tự hào khoác trên mình chiếc áo blue trắng, mỗi người thầy thuốc chúng ta luôn tự nhủ, ngoài sự cảm thông, yêu thương người bệnh, chúng ta luôn cần phải trau dồi và cập nhật các cái kiến thức chuyên môn của mình. Học tập là một quá trình liên tục và xuyên suốt trong cả sự nghiệp hành nghề của chúng ta. Học từ các thầy cô, từ anh chị em đồng nghiệp và từ chính người bệnh của chúng ta. Vì thế, các hội nghị, hội thảo khoa học, các khóa đào tạo liên tục luôn là những cơ hội để học tập và trao đổi kỹ năng nghề nghiệp của các thầy thuốc tim mạch chúng ta.
Ngành tim mạch Việt Nam trong những năm vừa qua đã có những bước phát triển vượt bậc. Các trung tâm tim mạch trên khắp cả nước đã có sự phát triển về cả chiều sâu và bề rộng. Hội Tim mạch Việt Nam cùng các phân hội là những tổ chức nghề nghiệp đã quy tụ được đông đảo các bác sĩ chuyên ngành tim mạch cũng như cộng đồng y khoa thông qua việc tổ chức các hội nghị, hội thảo và các khóa đào tạo liên tục. Hội nghị khoa học tim mạch toàn quốc năm nay là một minh chứng với sự tham gia của trên 300 các báo cáo viên, diễn giả nổi tiếng trên thế giới và trong nước, được phát cùng lúc trên 10 kênh trực tuyến và hàng loạt các chương trình đào tạo liên tục.
Chúng ta đã trải qua nhiều mất mát và thử thách. Nhưng hơn bao giờ hết, các bác sĩ chuyên khoa tim mạch sẽ nỗ lực đoàn kết hơn. Sự nghiệp bảo vệ tim mạch sẽ không bao giờ nghỉ ngơi, không giới hạn và không khoảng cách giữa mỗi chúng ta. Chào mừng quý vị đến với Hội nghị Tim mạch Toàn quốc Việt Nam 2021. Tim mạch học là một chuyên ngành y học hết sức sôi động và thường xuyên được cập nhật. Đại dịch Covid đã và đang thay đổi sâu sắc thế giới. Mọi khía cạnh của đời sống xã hội bị ảnh hưởng nghiêm trọng và đặt ra những vấn đề thách thức chưa từng có đối với các thầy thuốc nói chung và các bác sĩ chuyên khoa tim mạch nói riêng.
Vinh dự và tự hào khoác trên mình chiếc áo blue trắng, mỗi người thầy thuốc chúng ta luôn tự nhủ, ngoài sự cảm thông, yêu thương người bệnh, chúng ta luôn cần phải trau dồi và cập nhật các cái kiến thức chuyên môn của mình. Học tập là một quá trình liên tục và xuyên suốt trong cả sự nghiệp hành nghề của chúng ta. Học từ các thầy cô, từ anh chị em đồng nghiệp và từ chính người bệnh của chúng ta. Vì thế, các hội nghị, hội thảo khoa học, các khóa đào tạo liên tục luôn là những cơ hội để học tập và trao đổi kỹ năng nghề nghiệp của các thầy thuốc tim mạch chúng ta.
Ngành tim mạch Việt Nam trong những năm vừa qua đã có những bước phát triển vượt bậc. Các trung tâm tim mạch trên khắp cả nước đã có sự phát triển về cả chiều sâu và bề rộng. Hội Tim mạch Việt Nam cùng các phân hội là những tổ chức nghề nghiệp đã quy tụ được đông đảo các bác sĩ chuyên ngành tim mạch cũng như cộng đồng y khoa thông qua việc tổ chức các hội nghị, hội thảo và các khóa đào tạo liên tục. Hội nghị khoa học tim mạch toàn quốc năm nay là một minh chứng với sự tham gia của trên 300 các báo cáo viên, diễn giả nổi tiếng trên thế giới và trong nước, được phát cùng lúc trên 10 kênh trực tuyến và hàng loạt các chương trình đào tạo liên tục.
Chúng ta đã trải qua nhiều mất mát và thử thách. Nhưng hơn bao giờ hết, các bác sĩ chuyên khoa tim mạch sẽ nỗ lực đoàn kết hơn. Sự nghiệp bảo vệ tim mạch sẽ không bao giờ nghỉ ngơi, không giới hạn và không khoảng cách giữa mỗi chúng ta. Chào mừng quý vị đến với Hội nghị Tim mạch Toàn quốc Việt Nam 2021. Tim mạch học là một chuyên ngành y học hết sức sôi động và thường xuyên được cập nhật. Đại dịch Covid đã và đang thay đổi sâu sắc thế giới. Mọi khía cạnh của đời sống xã hội bị ảnh hưởng nghiêm trọng và đặt ra những vấn đề thách thức chưa từng có đối với các thầy thuốc nói chung và các bác sĩ chuyên khoa tim mạch nói riêng.
Vinh dự và tự hào khoác trên mình chiếc áo blue trắng, mỗi người thầy thuốc chúng ta luôn tự nhủ, ngoài sự cảm thông, yêu thương người bệnh, chúng ta luôn cần phải trau dồi và cập nhật các cái kiến thức chuyên môn của mình. Học tập là một quá trình liên tục và xuyên suốt trong cả sự nghiệp hành nghề của chúng ta. Học từ các thầy cô, từ anh chị em đồng nghiệp và từ chính người bệnh của chúng ta. Vì thế, các hội nghị, hội thảo khoa học, các khóa đào tạo liên tục luôn là những cơ hội để học tập và trao đổi kỹ năng nghề nghiệp của các thầy thuốc tim mạch chúng ta.
Ngành tim mạch Việt Nam trong những năm vừa qua đã có những bước phát triển vượt bậc. Các trung tâm tim mạch trên khắp cả nước đã có sự phát triển về cả chiều sâu và bề rộng. Hội Tim mạch Việt Nam cùng các phân hội là những tổ chức nghề nghiệp đã quy tụ được đông đảo các bác sĩ chuyên ngành tim mạch cũng như cộng đồng y khoa thông qua việc tổ chức các hội nghị, hội thảo và các khóa đào tạo liên tục. Hội nghị khoa học tim mạch toàn quốc năm nay là một minh chứng với sự tham gia của trên 300 các báo cáo viên, diễn giả nổi tiếng trên thế giới và trong nước, được phát cùng lúc trên 10 kênh trực tuyến và hàng loạt các chương trình đào tạo liên tục.
Chúng ta đã trải qua nhiều mất mát và thử thách. Nhưng hơn bao giờ hết, các bác sĩ chuyên khoa tim mạch sẽ nỗ lực đoàn kết hơn. Sự nghiệp bảo vệ tim mạch sẽ không bao giờ nghỉ ngơi, không giới hạn và không khoảng cách giữa mỗi chúng ta. Chào mừng quý vị đến với Hội nghị Tim mạch Toàn quốc Việt Nam 2021.